Okay, we are live on YouTube now, Madam Chair. Thank you.
Good morning, everybody. Welcome. It is Thursday, September 29th, and I will call the meeting of the Public Employees Benefits Program Board to order. And staff, would you please call the roll?
Laura Freed.
Here.
Linda Fox.
Here.
Betsy Aiello.
Here.
Jim Barnes.
Here.
April Caron.
Here.
Leslie Biddleston.
Here.
Jennifer McClendon.
Here.
Tom Verducci.
Here.
Janelle Woodward.
Here.
And Michelle Kelly.
Here.
Thank you. We have a quorum.
Okay, thanks. Agenda item 2 is public comment. So again, I will turn it over to pub staff to get us set up for that.
One moment, Madam Chair, I'll get the slide up. As a reminder, Zoom is used for public comment only. This meeting is streaming live on YouTube if you just want to listen to the PEB board meeting. The YouTube link is located on the agenda. For those who have joined for public comment, your name or last 4 digits of the phone number will be announced and you will be advised you have been unmuted. As a reminder for those on the phone, please press *6 to unmute. Please slowly state and spell your name for the record and then proceed with your comments. Due to time considerations, each caller will be limited to 3 minutes. Will the caller with the last 4 digits of 0891, please slowly spell and state your name for the record, and please press *6 to unmute. Caller with the last 4, 0891, please press *6 to unmute if you wish to make public comment.
Thank you. Good morning, Chair Freed and fellow board members. My name for the record is Terry Laird, T-E-R-R-I, last name L-A-I-R-D. I'm the executive director at RPEN, the Retired Public Employees of Nevada. We are a nonprofit, nonpartisan organization where we represent close to 7,500 members within 17 chapters statewide, and we've been around since 1976. We are happy today to learn through PEB Executive Officer Laura Rich's report that staffing levels have improved, although that same report suggests it could be months before the new staff is fully trained and able to assist the many active participants as well as the many retirees who've needed assistance and guidance through the many issues that PEB has had with vendors over the past year or so. We remain hopeful that PEB will receive legislative assistance next year to return PEB to pre-COVID funding levels. And RPEN, along with our fellow advocacy members, will lobby to support that effort. Until then, I'd like to thank Ms. Rich and her staff for going the extra mile to help our members in need when asked, and in such an expeditious manner. Thank you for your time.
Thank you. Well, Kent Urban, please, you have permission to speak. Please make your public comment.
Thank you. Kent Irvin, K-E-N-T-E-R-V-I-N, State President, Nevada Faculty Alliance. Good morning, Chair Freed, Executive Director Rich, and board members. Thank you for your service. The state of Nevada has a dire employee crisis on its hand. State agencies, including PEB and NSHE, cannot fill vacant positions because the compensation and benefits are deficient compared to the private sector and compared to cities and counties and nearby states. The PEB benefit should have been restored for the current plan year using American Rescue Plan Act funds. We don't understand why not. But now Governor Sisolak has told the Nevada Faculty Alliance that he supports restoring PEB benefits. The highest priority for FY 2024 is to fully restore benefits and premiums to pre-pandemic levels or better. My written comments provide some details for consideration. For the high deductible plan, deductibles should be kept at the IRS minimums, the out-of-pocket maximum should be reduced, and HSA contributions should be substantially increased, including for dependents. For the HMO EPO plans, the deductibles and co-insurance should be zero. The point of HMO type plans is that the higher monthly premiums are paid with the expectation of fixed copays and no surprises in billing. The low deductible plan should be structured to be in the middle with a low deductible. Long-term disability insurance should be restored. It's also time to increase the maximum annual dental benefit, which is at the same dollar amount as it was in 1990, while dental costs have increased 3 or 4 times. We are opposed to the idea of eliminating the Northern EPO plan without providing another alternative comparable to the HMO in the South. One of the stated core values of PEB is fairness, and it would be patently unfair to eliminate this option for one group of state employees based on geographic location. PEB perhaps should explore other options as outlined in my written comments. Finally, as also shown in my written comments, we see again that the new excess reserves were generated in FY 2022 despite spend down plans. This has been going on for a dozen years. You now have at least 9.5 million to work with for employee benefits that should have been used now to benefit current employees, and it should not wait until more state employees quit. Restoring basic plan benefits to pre-pandemic levels should be the highest priorities before investing in new and unproven programs. Thank you.
Thank you, Mr. Irvin. Will the caller with the last 49199 please slowly spell and state your name for the record? And you have permission to speak for public comment.
Good morning, Chair Freed and members of the board. For the record, my name is Tess Opferman. That's TESSOPFERMAN, speaking on behalf of AFSCME Retirees, Chapter 4041. As Ken just addressed, excess reserves continue to be generated yearly at PEB, and despite reported efforts to spend down these reserves, we still see nearly $40 million in excess reserves for fiscal year 2022. These excess reserves are monies that could be used to provide better benefits to our retirees and restore benefits to pre-pandemic levels. Additionally, the continuous cuts at PEB benefits have made a notable impact on the ability to hire for state positions in every department. Historically, somewhat lower wages were counterbalanced with strong retirement benefits at the state. Now, with low wages and decreased benefits, the state is in an employment crisis. Restoring benefits should be the top priority for fiscal years, including a full restoration of long-term disability, increasing the HSA employer contribution, keeping employee premiums at no more than current premiums or preferably pre-pandemic premiums, and for the HMO EPO plan, restoring zero deductibles and zero co-insurance. Finally, the proposed elimination of the Northern EPO plan should only be considered if it is replaced by a plan comparable to the Southern HMO plan. Limiting medical care options based on geographical location is inherently unfair and goes against PEB's stated core values. We look forward to the presentations today, and thank you for your time this morning.
Thank you. Will the caller with the last 4 digits 0962, you have permission to speak. Please slowly spell and state your name for the record, and unmute your phone if you want to make public comment.
Hello?
Good morning, we can hear you okay.
All right, thank you. My name is Natalia Filson, last name F as in Frank, ILSON. I am an administrator for a private dental practice in Carson City, Nevada, Dr. Funka, DDS. Our public comment is on a recent switch of state employees and retirees benefit to administrator UMR. We've encountered multiple issues with that administrator. Our patients have been advised that none of their benefits will be changed. However, we've noticed multiple changes where services have been downgraded, or as the insurance company calls it, considered alternative treatment, which is usually a lower cost, which puts more pressure financially on the patient. This practice, executed by insurance companies, forces patients to choose a treatment that might not be optimal for their dental health needs, and it can cause long-term impact on their dental and overall health. But it does benefit insurance companies financially, and insurance companies should not dictate patient treatment. Also, from the administrative standpoint, very difficult to deal with this administrator. It generates enormous amount of time and resources, which small businesses cannot provide at this time. And lots of denied claims are put back on the patients, forcing them to either deal with it or pay out of pocket, which denies them the benefit that they entitled for. And that's our statement. Thank you.
Thank you. Will the caller with the last four digits 8673 please slowly state and spell your name for the record and proceed with your comment?
Good morning. My name is Brooke Maylath. That's BROOKE MAYLATH. I've spoken before this board numerous times, last in the May 24th meeting, where Chair Freed stated that the issue that I brought forth about the pre-certification for transgender patients accessing hormone replacement therapy is patently illegal. During the May 24th meeting, Chair Freed stated, for the record, I will ask for this to be brought back at least as a discussion item, perhaps an action item, depending on what the lawyers have to say next meeting, because I would like to understand better the legal standard for making a master plan document change mid-year. I would like to understand the pros and cons of what Member McClendon suggests, because if we don't have prior authorization for someone going through menopause, why do we have prior authorization for people going through gender transition? Those are some very good questions that never were brought up in the July meeting, which was the next meeting. That discussion is not even agendized for this meeting. Words matter, especially in a public meeting context. Why are we not having this discussion? We need to understand what you're going to do to remove the liability that continues to compound. Please refer to my written public comments to be able to see how these liabilities are stacking up with recent editions of the updated Standards of Care for Transgender Health, version 8 from WPATH, as well as the new rule defining discrimination under the Affordable Care Act. And last, which is not included in the written statement, the August 10th ruling for a permanent injunctive relief in federal court by U.S. District Judge Biggs that found that the exclusion discriminates on the basis of sex and transgender status in violation of equal protection in Title VII. You're out of compliance with federal law. You're out of compliance with state law. Please, let's get this resolved. before we have to resolve it in court. I thank you for your time. I look forward to seeing this agendized and advanced as quickly as possible, perhaps even in this meeting. I'll be watching. Thank you.
Thank you. Will Constance please slowly spell and state your name for the record?
Yes, good morning, board. I'm Dr. Constance Sheltren, and the name is spelled Constance, C-O-N-S-T-A-N-C-E, last name Sheltren, S-H-E-L-T-R-E-N. I am a licensed psychologist and owner of the and clinical director for the Center of Psychological Wellbeing. I have been treating state employees for 14 years, and I employ 3 other clinicians as well as myself. I pay my clinicians at the time of service, and which works fine as long as I'm getting paid. Prior to July 1st, we generally receive from HealthScope payments in 2 weeks after electronically submitting claims. There was an initial lag when Aetna took over last year, and it was about 45 days. But the transition to UMR has been a real challenge. Finally, I contacted the governor's office at day 81 of not being paid. I'm a small business and do not have the cash flow to sustain my business without receiving payments. Prior to calling the governor's office, my office manager had contacted UMR numerous times. The responses from UNR were things like, "We're working on it. We will check with this and get back to you," which did not happen. "You will get checks in 2 weeks." That did not happen. "It will take up to a total of 60 days. We were at day 81. And then shifted to blaming the state of Nevada with comments like, "The state wants to have all of this training of processing claims correctly. We have not been able to get the staff trained on their process. PEBP is very picky." So, and my office manager had also tried to reach out to PEBP, but was either put on eternal hold, I'm talking about 1 to 2 hours, and then got transferred to UMR. So it was like this vicious cycle that got nowhere. But after contacting the governor's office, Laura Rich reached out to me, and everything changed. We could see claims being processed within 24 hours, and we did receive payment on Tuesday, September 27th, or day 89. We are hoping the process of claims will continue to move forward from this point on, but it was obviously a big problem. One other side comment that I would like to make about contracting with insurance companies like for next year is that I would like you to consider mental health coverage. Some insurance companies want to pay absurdly low rates that only those who work from home online could afford to accept. Furthermore, when insurance companies show you a list of mental health providers for those low-paying insurance, most of the providers are not willing to accept any new patients. Simply, they can't stay in business if they do. I'm just simply suggesting that you consult with mental health providers prior to making decisions about what insurance company you will use for the following year. Thank you.
Thank you. Will Doug Unger please slowly spell and state your name for the record if you wish to make public comment?
Doug Unger, D-O-U-G-U-N-G-E-R, President, UNLV Chapter, Nevada Faculty Alliance and Government Affairs Representative. Thank you, Chair Freed and members of the board for your consideration. Nevada is in the midst of a state employee shortage that has driven many state agencies and vital services into partial dysfunction. If not remedied, this crisis will become catastrophic. and may be so already in some agencies. Deficient entry-level salaries, including starting salaries for many ranked levels of NG faculty and staff, are clearly one reason for this. So are PEB benefits, widely perceived as inadequate compared to what they once were, and ever in danger of unanticipated cuts. In sum, state employees are sick and tired of seeing their salaries and benefits used like a bank account, raided and emptied to balance Nevada's budget, so they are quitting. Very few applicants are willing to replace them for subsistence or less. Implementing the budget the PEP board submitted to restore health and other benefits to pre-pandemic levels, including life insurance and long-term disability insurance, is one part of a remedy needed to address deficient compensation for state workers, a remedy that is going to take years. Thank you for submitting that second budget. We hope it's approved. For today's agenda, we support Executive Officer Rich's proposal to study and report costs for augmentations of the plan design, especially the cancer concierge, medical travel, and Hinge Health. In the interest of fairness, we do not support elimination of the EPO in the North without preserving a third choice HMO, either self-funded or by seeking a new contract. However, more impactful to state employees than proposed augmentations would be reducing maximum out-of-pockets, increasing contributions to the HSA and HRA accounts for the HDHP plan, and to lower copays and deductibles for the PPO to make it more desirable. Thank you all for your support and service.
Thank you. Will the speaker, Julie K, can you please slowly spell and state your name for the record if you wish to make public comment?
Oh, my apology. I didn't request to speak, so sorry.
Okay. Can you please leave the Zoom meeting then? It's only for public comment. Thank you. If you wish to watch, please watch on the YouTube that's being streamed right now. You can get the link on the agenda.
Got it. Thank you.
Madam Chair, that concludes public comment.
Okay, thank you very much. Wait a second for the slide to come off and move on after that. So, okay, agenda item 3 is PEB board disclosures for applicable board meeting agenda items. I will toss it to Chief Deputy Attorney General Briggs. Good morning, Ms. Briggs.
Good morning, Madam Chair. Thank you. This agenda item is to allow me to make a disclosure regarding conflicts of interest on behalf of the board members who receive or are eligible for PEB benefits. Certain items on the agenda may have a direct or indirect effect on those benefits. Pursuant to NRS 281A.420, on behalf.
Oh, I'm sorry.
I'm sorry, go ahead.
No, I realized I was still. I have no disclosure. I'm just sitting here coughing and not really.
Oh,
should have been on mute.
Okay, so pursuant to NRS 281A.420, on behalf of the board members who are eligible for PEB benefits or whose families are eligible for those benefits, I offer this disclosure that they will be voting on those items that may affect the benefits available to them or their family members. The law does not require abstention from voting merely because the board member is eligible for PEB benefits. At this time, I invite any member of the board who has any other additional disclosure to make to do so now. Thank you.
Okay, hearing none, I will move on to agenda item 4 then. As you all know, agenda item 4 is our basket of reports that we typically get, including the budget report, utilization report, vendor reports. Members, do you wish to pull any of these reports for discussion before I take a motion to accept all of them? Mr. Verducci, got your hand up.
Yes, Tom Verducci for the record. I would like to pull section 4.2.1, the budget report. 4.2.1.
That sounds good. Thank you. I was going to do same. So thanks for saying that for me. Any other? Okay, hearing none, I will take a motion to accept all of the items on except for 4.2.1.
This is Leslie Biddleston, so moved.
Thank you, Ms. Biddleston. Do I have a second?
Michelle, second.
Okay, thank you. It's been moved and seconded to approve everything except 4.2.1. All in favor, say aye or raise your hand in your little box.
Aye.
Aye.
Aye. Any opposed, say no. Okay, motion carries. Thank you. Okay, I don't know whether we'll turn it over to Ms. Rich or Ms. Eaton for the budget report, but I'll let staff take it away.
I will pass this off to Miss Eaton since I know that she went back and forth with GFO quite a bit on this. So, but I think, can we start off maybe with, if there's any questions from Mr. Verducci, so she knows what exactly to address.
Oh, sure. Thank you for that. Mr. Verducci, take it away.
Okay, thank you. Tom Verducci for the record. In reviewing the budget, I wanted to see if we could just get some clarification on the differential cash that's available. I see some, different figures that have been presented in public comment, and I see the word revision forward. I was wondering if we could get that defined with the wording revision forward, how that would affect the differential cash. And I do see that there is a actual 2022 fourth quarter number in the report of 23,491,000. And I was wondering if we could just get some clarification on what the actual close of the differential cash or excess reserves is for 6/30/22, if that is available.
Thank you. This is Carrie Eaton for the record. Excuse me. The reversions that are shown in this report of the $8.7 million, the 8,667, that is, if you'll recall, back in December, the board voted to enhance the plan design with using $26 million of excess reserves and over a three-year time period. So the GFO requested that PEB move the FY22 funds to FY23 for the FY23 plan design prior to closing. So that's why they call it a reversion. So it kind of complicated the closing a little bit. So technically you could add that 8.7 million onto the differential cash available of 30.2 million for where we actually closed 2022. And that's why I added the not including reversion in the 23 section of this report. So it all does just pan out, and we still are opening fiscal year 23 with 33.1 million of differential cash.
Mr. Verducci, may I interject? Okay, I was going to have the same question. The difference between what I see in the state accounting system of total balance forward of 33.1 as opposed to the 23,491,056 shown in the chart on page 2. And it sounds like GFO wanted PEB to do a partial balance forward first and then do the closing work program. Sure, why not?
This is Carrie Eaton. Yes, they did. And I it made closing pretty interesting. And I already said I am not doing that again this year.
Okay, cool.
I hope.
Thank you for the clarification. So where we are basically is we balance forward 148.9 million. Of that, we've set aside 26 million plus actually for 23, 24, and 25 for plan design. And now as we're going to talk about later in the meeting, we've got 9.5 million that's true excess cash.
Carrie Eaton for the
Okay.
record. Correct.
All right, cool.
Yes. So the 33.1 million that we're starting with does not include the 8.6 because that's already in an expenditure category because
Oh,
it's
okay.
included in the plan design.
I got you.
So
Okay.
the 33.1 includes the 24 and 25.
Okay. So
And
that
then-
was the rationale for the partial balance forward.
Yeah, yes.
You got to park it in.
I mean, it could have happened at closing as well.
Well, right,
It would
yeah.
have all shaken out the same and a little
Yeah.
bit less confusing.
Yeah, it's an extra work program.
Correct.
All right, that's super. Thank you for the clarification. Mr. Verducci, please, now I got that straight in my head, but please continue. with your
It might
question.
only be, might only make sense to you and I.
Well, thank you so much, Chair Freed and Ms. Eaton. So, I believe we've had discussion of spending down on excess reserves, and I see some figures here that they've actually gone up for 13 years. And, we have two budgets that are going to be presented, I believe, at the December 5th meeting. And in terms of fully restoring benefits, I recall it was in the neighborhood of 6.3, 6.4 million. Do you recall the figure that we were working with earlier in the year that would entail a full restoration of benefits to the pre-pandemic level? I know it's not in this budget, but I kind of remember it was in the $6 million range. And where I'm going at with this is it seems that it may be somewhat affordable, and all of the public testimony was requesting that we have full restoration of benefits. And I like that idea too. I think it'll make the state of Nevada a premier employer with enhanced benefits. Raises have gone on for a long time. There's been no raises. And I think what we can do is we can put in a request to restore the benefits, and it seems affordable unless I'm missing something.
Mr. Verducci, I think I'm going to ask to table this until we get to agenda item 9. I'm sorry, agenda item 10, because that's when we're just going to discuss what the board's desire is with this $9.5 million.
Okay. Thank you very much. I'll go ahead and table my comments until we get there.
Okay, thank you. So with that, does anybody else have questions on the budget report? Okay, hearing none, I will accept a motion, probably from Mr. Verducci, to accept the budget report.
Tom Verducci, so moved.
Thank you. Do I have a second?
Janelle Woodward, second.
Thank you. All in favor, say aye.
Aye. Aye.
Any opposed, say no. Okay, motion carries. Thanks, everybody. All right, so that takes care of number 4. Let's go to agenda item 5. And agenda item 5 is election of the board's vice chair. Pursuant to NRS 287-0415, the governor has designated me as board chair. And so until he designates somebody else, which he could do, I'm the chair and I get to continue to be the chair. But in NAC 287-172, at the first meeting in the new plan year, we are to elect a vice chair from among ourselves. And so we didn't do it at the first meeting because we were waiting on some vacancies on the board to be appointed. Though we still have, I think, 1 vacancy. We need to do this since we didn't do this in July. So before I ask for nominations, I want to thank Linda Fox for being the vice chair. She's been the vice chair for, 2 years, Linda, or 3 maybe?
I think it's been 3 years.
3 years, yeah. Thank you very much. So with that, I will accept, you may nominate yourself or you may nominate somebody else. So I'll open it up. Mr. Verducci, you have your hand up.
Tom Verducci for the record. I wanted to point out that, I believe Jim Barnes has been chairman of the Washoe County Planning Commission, chairman of the OSHA board, I believe Truckee Meadows Planning Commission and Deferred Compensation, the Deferred Compensation Committee. And he's done that in the 80s, 90s, 2000s, 2010s, and 2020s. And I've seen Mr. Barnes conduct meetings going back to the late 80s. And in terms of his legal background, his commitment, I think he would do a fine job stepping in and being able to conduct meetings in a very professional manner. And I'd like to nominate Mr. Barnes as vice chair, if that is possible at this point.
Thank you, Mr. Verducci. Mr. Barnes, do you accept?
Yes, I'd be happy to accept.
Great. All right. Ms. Briggs, Ms. Rich, do I need a motion and a second on this one? I assume I do.
Yes, you do.
All right, thank you.
So Chair, Linda Fox, for the record, I will second.
Okay, great. So it has been moved by Mr. Verducci and seconded by Ms. Fox to have Mr. Barnes serve for the next year as vice chair of the PEB board. All in favor signify by saying aye.
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 Any opposed? Great, motion carries. That was so easy. I thought I was going to have to browbeat you guys by threatening to pick somebody myself. Thanks, everybody. Congratulations, Mr.
Thank
Barnes,
you.
I think.
Thank you.
Okay. With that, I think we can move to agenda item 6. And this is an interesting one. This is a discussion item only, but it is, as we heard in public comment, and as I've been made aware of, and I think other board members have been made aware of, we have some delays in claims payment cropping up in the transition from HealthScope to UMR. And so I think I will ask Ms. Rich to give a little bit of context, and then I will ask UMR to walk us through the series of charts that they have provided and give board members a chance to ask questions. Does that sound okay? All right. With that, I'll let Ms. Rich take it away.
Right. Laura Rich for the record. So just to provide a little bit of background, and I think we've got some folks on here from UMR who are going to go into it in more detail, but to provide some insight on it, I was first made aware, it started out with dentists in, especially in Carson City, where there's a large percentage of state workers were calling PEB and making our office aware that, hey, there's some issues there. UMR is not paying, there's some lag time, we're getting close to 90 days. That then became a larger problem because then it was more providers. We started hearing from more providers. So at that point, I engaged with UMR to see what was going on. There was definitely a delay. Part of it was due to some coding issues, which you'll hear about today from the UMR group in that transition. It is when we go from one TPA to another, there's certain, every client has certain different benefits, right? And how those benefits are applied. And so the coding rules have to be changed specifically for that client. What ended up happening was a lot of the PEB rules, and this is what actually you'll hear me talk about in the executive officer report. I'm going to mention the compliance, but we're doing a deep dive compliance and review. And so this really does, it highlights how important that compliance review is, because what we found out is that there was a whole lot of coding that was needed because PEB has a lot of antiquated, non-standard benefit rules and how we pay our benefits. And so specifically for dental, but this is, also for things in, on the medical side as well. So, so there was a lot of coding that needed to occur to transition. You don't want to process claims until you know that they can be processed correctly. Because then if you have to reprocess them, it creates a whole lot of disruption, not just for providers, but also for members. You have to redo the accumulators and things like that. So there's a whole lot of disruption. So it is better to do it right the first time than to have to reprocess it. But that obviously caused some issues in the provider community. And so I think I'm going to pass this over to the UMR folks because they're going to give you a lot more detail to this. There has been a lot of progress that's been made in the last couple of weeks. I know a lot of payments have gone out. They are getting back to normal, but this was a bumpy transition in terms of those claim payments. So I know it looks like Rhonda has joined. Rhonda Huckabee, are you going to be giving this report, or Nathan Meyer?
Yeah. Hey, Laura.
Nathan, okay, you're going to take it off. Okay.
I'll just give a quick high level, then pass over to Rhonda and then Darren. So Nathan Meyer, for the record, Director of Account Management for UMR. I would, echo everything Laura said. We certainly, uncovered some things through the migration, some expected, some unexpected. There are some complexities to the PEB benefits, and, there was some misinterpretation between the teams as we were setting up the system, which to Ms. Rich's earlier point caused us the need to put the claims on hold as we worked through those and, to ensure that claims are out the door correctly. But that certainly did cause claim delays like we heard in public comment. We have made a lot of progress in the last few weeks on the inventory, and, happy to report that we are, nearing historical inventory levels, and we'll go through some detail on that shortly. Like I said, we made some good progress and we feel good about go forward. But yeah, all the things I just mentioned certainly did cause claim delays and some disruption in the provider community. And, we do apologize for that. But like I said, we have made some really good progress over the last few weeks. So with that, I'm going to turn it over to Rhonda to go through some of the specifics of the transition items. And then she's going to pass over to Darren Ashby in our operations leadership to go over inventory levels as of Monday, turnaround times, post-migration, claim turnaround times. And then also, I think we got some updates as of this morning in terms of the inventory levels as of today. So with that, I'm going to turn over to Rhonda.
Good morning. This is Rhonda with Rhonda Huckabee, for the record, with HealthScope, now UMR. And as Laura and Nathan have both previously stated, during the controlled releases that we did starting in July, as the claim inventory came in for the new plan year, effective 7/1/22 and forward, we discovered some discrepancies, which were, as Nathan stated, misinterpretations between the HealthScope and the UMR staff. With that, we decided to put the claims on hold, and then we went back through each type of benefit to make sure that everyone understood the client's intent, as well as to ensure that the claims were processing accurately with the initial release. Because as Laura stated, when we do have to reconsider claims, especially on the high deductible where we have the interface with the prescription accumulators, it does cause issues for the providers as well as the members. We did send email blasts to the dental community with the assistance of Diversified Dental. And we also did a medical email blast to all of the contracted providers, just to kind of give them a heads up that we were hearing what they said, we understood, and we were working on getting their claims paid. And as Laura Rich mentioned, some of the things that we identified are just the PEB nuances of the plan. Most of them, especially with the EPO, where that is a regional plan that is specific to the 14 counties in Northern Nevada. Some of the challenges that we have is just when we have participants and their dependents do not reside in the 14 counties. So it's kind of like a split plan. Those require extensive programming, and those are some of the things that we had to put the claims on hold and go back and look at, because anything outside of the counties requires gap exceptions by the vendor, and then we have programming in place in the system to try to catch every scenario, but sometimes that requires a lot of manual intervention. Some of the other items that Laura Rich mentioned were I wouldn't call them discrepancies, but it was differences in the PEB dental current plan design and how UMR codes very specific down to the ADA code. And that generated some conversation between UMR and PEB. And we have already scheduled a call with the quality control officer and claims technologies, who is the auditor, to do a deep dive into the plan documents, as well as what Siegel is performing the compliance review on behalf of PEB. Some of the other items are just, as Laura said, the PEB nuances around the 50-mile rule, how we do what we refer to as the ology benefit when they're at a contracted facility and or provider, and that provider sends them or uses a non-contracted provider. So we had to go in and tweak what we call the ology rules to make sure that the UMR claims platform was applying the benefits in the same manner that the HealthScope platform had previously done. All of this, as Laura said, led to some, conversations that we need to have, understanding the plan's intent and making recommendations to update the MPD with those clarifications, because that's an ongoing process. We do this every year with the PEB staff, but this year we are going to take a deeper dive into the plan documents to ensure the plan's intent is well stated in the plan document, just to support us during provider disputes and member appeals. Laura, do you need me to address any other type of benefits?
No, I think you got it all covered. Thanks, Brenda.
Okay. And certainly if there's questions, we can ask them. And based on public comment from Dr. Shelton, we have, ensured that her claims were paid, and we ran a report this morning. And at this time, we have no pending claims on file. And we would like to publicly apologize to Dr. Shelton, and we should not have this issue going forward. Thank you.
Thank you, Ms. Huckabee. I appreciate that. I knew it. I have questions, but I knew if I opened it up to the board members, they'd jump on it. So I think Ms. Kelly rang in first. So I'm going to go Ms. Kelly, Ms. Biddleston, and Ms. Aiello.
Good morning. Thank you, Chair Freed. My question, I guess, is for someone from UMR. I'm not really sure. I guess I'm just really surprised and actually unhappy. It seems like whenever I implement a large contract, which certainly claims paying is a massive contract, there's significant testing done, and there's a whole lead where I would have expected you'd go through the plan documents, even though UMR and HealthScope are related, if I understand it correctly. It was still a new implementation, and it seems like the implementation failed, frankly. On July 1st, you guys should have been ready to pay the claim. The plan design did not change very much. And so I guess, I'd like to hear what the implementation plan was and how that clearly wasn't executed. And then secondly, I guess I just wanted to put on record that I kind of take exception to using antiquated benefit rules, terms like antiquated benefit rules and non-standard benefits. in all honesty, that makes me feel like that there is a goal to maybe diminish the benefits as we work through the plan document. And so my request after hearing kind of that kind of language is that any changes to the plan document that comes out through this detailed review, each and every one, language change, benefit change, highlighting, actually comes to the board so that we can see what UMR is actually requesting. And the reason for that is that any change in language, any change in interpretation of how something works will impact our members. And if a member is used to pay something being paid one way and suddenly it's paid a different way and potentially it's paid at a lesser percentage, so the employee share goes up, that's a concern. You know, we will hear about that and we need to be in front of that. And with that, thank you.
Can I address that before UMR, if possible? All right, Laura Rich for the record. So I just wanted to, I want to address both of your points, Ms. Kelly. Being devil's advocate here, I do have to say that there were many, many implementations going on at once, and that is not the norm. And so there were, you know, we were implementing the HSA, we were implementing the, you know, going over to the new TPA, the network, things like that. So all of it kind of runs through the TPA. So there's multiple integrations with the TPA happening at once. And if you recall, the biggest one of all was the enrollment and eligibility system. HealthScope and UMR were very, very integral in that part and had to dedicate a lot of time and hours to fixing that and going back to LifeWorks. And so there were definitely a lot of things going on at once. And while I do agree that more testing should have been done and that we probably should have addressed that because of its importance, I do just want to put that on the record that there were a lot of integrations happening at the same time, and that is not normally the case. We would try to avoid that at all costs because of these types of situations specifically. The second one is, you're absolutely correct. That's why we're doing this compliance review. We will be bringing it to the board. I'll be talking about it during the executive officer report, but we will be bringing it to the board. And that's why we're doing it during this time frame, so that we can bring it to the board before, hopefully by January, so that we can get this all into the next plan year documents. It does not mean that these are benefits that we're looking at downgrading. It's actually the ones that I've seen are the opposite, especially regarding dental. It's things like, you know, do we want to continue paying for silver fillings? Maybe we need to look at, you know, the standard now is composite. Maybe that's what we need to start, you know, looking at and changing to adhere to. You know, when I say antiquated, most people aren't getting silver fillings anymore. Most people want those composite fillings, right? So those are the things that we're looking at. They're not exactly downgrading, like the 1500. That was, I think that was brought up during public comment. We haven't changed that 1500 max in like a decade. So we're looking at, you know, is that still appropriate, right? So there's things like that we're looking at, and we will bring everything back to the board. We're expecting to bring it back to the board in January. So Rhonda or Nathan, if you want to add anything to what I just said, feel free.
Yeah, hi, Nathan Meyer for the record. So we did do testing, of course, as we always do for migrations, implementations, and obviously, you know, we missed some items in testing. You know, some things have to be in the production environment to test. So the network, for example. So PEB's got a pretty complex network configuration, and with the change to the new network, and the routing to the various networks can only happen in the production environment. So, that's just an example of, something that we had to wait until production to thoroughly test. And if you think about, the way claim billing works, so yes, we went live 7/1, but most of the claim volume was being paid on Health Access throughout all of July. So we really didn't start seeing claim volume come in to the UMR system until end of July, early August, which is when we could start our controlled release. And then we started identifying some of the issues that Rhonda identified. Yes, I would have liked to have seen us, catch, whatever we could through the test environment. Again, there were some misinterpretations of the benefits between the teams, which caused us, missed opportunity there on some of the benefits. And to Laura's point, not making excuses, but we got eligibility pretty late in the process, which has kind of put us behind schedule. Again, not making excuses, just putting that out there for context. So, yes, we did testing. There was some misinterpretation between the teams as to how the claim should have paid that we then identified in production. And then to what Rhonda spoke to earlier, we made the decision to put everything on hold as we worked through some of those discrepancies. Rhonda, anything you would add to that?
Can you guys hear me?
Can now.
Okay. Yes, I would just like to kind of elaborate on what Laura, Rich, and Nathan both had presented. And yes, Mrs. Kelly, we were doing several installation meetings. At one time, we had about 13 different install and implementation meetings going on, and PEB staff were included in most of those, as well as implementing some of the new vendors for 7/1. And yes, we did have a approximately 6-month implementation where we meet weekly. We discuss, we break down the benefits one at a time, from an office visit to Cairo to hospital. But as Nathan said, there were some misinterpretations where some of the staff did not truly understand PEB's intent and or recommendations that we had previously received from PEB's auditor that we were trying to put into place to make sure that when we started paying claims on the CPS, which is the UMR platform, that they were processed in the same manner that they were while we were doing runouts on the HealthScope platform. We did spend about the first 3 weeks in July working through some of the eligibility issues. And I'm sure LifeWorks can, confirm this. We were trying to look at discrepancies on what we had received from Benefit Focus, and then what we started receiving from LifeWorks in May, because in our system, some of that information did not sync up. So we spent approximately 3 weeks cleaning up the eligibility. And as Nathan said, at that time, we did not have a lot of claim volume on the UMR platform. Most of the processing was still doing the run out on the Health Access platform.
Okay, thank you. I'm going to go to Member Biddleston.
Thank you, Madam Chair. Member Kelly kind of brought this up, but I want to present a question to, I don't know, I guess it's UMR. So anything that's not paid by a provider is usually passed on to the patient consumer, especially dental, the PPOs, all of that. So my question, whereas it's disturbing to hear that providers were waiting for long periods of time, my question is around, were dental providers and other providers paid, but paid incorrectly and costs incorrectly moved to the consumer or the patient based on some confusing algorithms or whatever it is. So I guess maybe what I'm trying to say is, will the compliance report pick this information up to see if, some providers were paid incorrectly, therefore passing costs to consumers incorrectly? I hope that makes sense.
Darren or Rhonda, does one of you want to take that one?
This is Darren Ashby for the record. I am Senior Vice President of Operations, joined UMR in 2019 as part of the HealthScope benefits acquisition. So in answer to your question, there could have been some claims that were processed early on incorrectly that could have resulted in a balance owed by the member. In most of those instances, it was brought to our attention by the provider community and adjustments were completed, therefore avoiding any out-of-pocket expense from the member being necessary.
Okay. Member Biddleston, do you have a follow-up or shall I move to the next question?
I don't know if I really have a follow-up. This one I actually experienced myself. So I'm just, I'm just kind of wondering if everything was caught and, especially around the dental claims and stuff like that. So I'm just making a point that I've seen and have heard about folks having copays for dental that they've never had in the past. And that could be due to some changes, or it could be due to claims paid incorrectly. Right. I guess I'm just trying to differentiate, were claims paid properly? That's what I'm trying to differentiate.
Okay. If I think with that, I will move to Member Aiello and then followed by Member Woodward. I saw Ms. Colrin had her hand up, but then it was down, so I don't know if she had a question also. But I'll move to Betsy. And give her
I want to say that actually I agreed with both members Kelly and Biddleston with what they were saying, and I was having the concern that people, as we've been hearing, a lot of folks have been choosing what they can and can't do. And in this time period, it could be dental, but it could also be other services, not just the dental, that folks have had to been picking up things. And it might be part of the dissatisfaction with people thinking more things have been cut than maybe actually have been cut. And I don't know, I would ask staff if there was a way, now that claims have paid, if people can run either what happened during the delayed pays, run reports, or claims that were reprocessed and paid differently, to try to understand if some of our clients have had to pay things and maybe make them give them some sort of notice that their doctors or physicians are now have been paid, because it might be hard for them to keep track. Even the physicians, we're relying on their systems to now say, whoops, I charged the client and now I'm being paid this many days out, so now I owe the client money back, and that just something to throw out there. The other thing I wanted to bring up was the customer service side of this that we heard, because that's a concern. I did hear in the report that yes, we sent bulletins out or provided information out, but it sounds like that some of those providers that did spend the time to call and outreach both to UMR and then to PEB, and we understand how short-staffed PEB have been, didn't, maybe if they understood totally what was going on, might have had a little bit more understanding and not kept reaching out, because I do understand too, small businesses that operate on cash flow can't go as long as larger entities, but customer service and understanding can go a long way. And I could say that I know how short-staffed the government has been, but I would have been very, very unhappy if I waited 2 hours on the phone just to be returned to an entity I tried to get help from 3 or 4 times. And in this tight provider environment, it's just, so I just wanted to bring that out to the customer service level. If we really knew this was going on, could there have been someone that went to providers' offices or something, just throwing ideas out so that maybe something like this wouldn't happen in the future.
Thank you. I'm not, is there?
I don't, there's not really a question.
Okay.
It's more, I think I'm more
Okay.
let's learn from this,
right?
Because it's in the past, other than throwing out the idea of, is there any way to run reports so that maybe if provider clients, some of our clients have paid things they shouldn't have, it would help them.
Okay. Okay, with that, I will go to Member Woodward. You're on mute.
Thank you. I guess I haven't learned that in the last 2 or 3 years. My apologies. Mine is just a comment as well. And I know that I interacted with Laura Rich on this, and she took care of it immediately. I heard the same thing when I went to the dentist, and my dentist said, your provider is not paying. And she took care of that immediately. I guess my comment is just that it maybe, and it echoes Ms. Aiello and everybody else, as soon as you know something, that there's an issue, notify everybody. Communication is always the issue with every incident that we have for any situation. And so the sooner that we communicate, there's an issue, it's going to take a little bit to fix, the less they're going to say, hey, your provider's not paying us, what's wrong, and they're crappy, whatever. And it's not just the, you know, the bumpiness of what happens, because we know that that happens anytime there's a change. Issues are going to come up. So that's it.
Thank you. Does any other board member have their hand raised? I'm not seeing anybody. Okay, with that, I'm going to start in on my questions, which are probably tangential to a lot of what other members have said, but I've got a couple of yes, no questions and a couple of explain this to me questions. So I'll start with the graphs that were submitted by UMR. Because there's no narrative, I wasn't sure what I was looking at. And I've got a series of tables of claim inventory, claim inventory. And I assume some of these are dental and some of these are medical. UMR, would you please talk me through these charts on these successive pages so I can label them?
Absolutely. This is Darren Ashby for the record again. So to start with the top of the page there of the reports, where we have claim inventory 7/1 through 9/23 of 2022 weekly. That represents the dental claim inventory. And what this is showing, you is a week by week total inventory. And
Mr. Ashby, why is there a blank on the September 2nd, 2022 column?
I believe that has to do, you know what, I apologize. I'll have to look into see why that says 0.
So as of September 26th, we have 8 dental claims over 30 days old.
That is correct.
Okay.
And
All right.
and then, I'm sorry, go ahead.
No, it's okay. Go, please.
No, I was going to say, and just to provide an update, as of yesterday, we were actually under 200 claims in total inventory with 0 claims over 30 days. Of course, throughout the week, that volume will ebb and flow.
Sure.
So as of this morning, we're actually at 665 claims in inventory, but still 0 claims over 30 days.
Okay. All right. And so on the next page, we've got, again, that same chart in that same format. Is this medical, since we're talking about 25,713 as of 9/23, or what?
That is correct. This represents the medical claim inventory.
Okay. All right. And then on the third page, as of 9/24, 1,005 claims. What is that?
Okay, so that represents the health access environment and the number of claims that are in total inventory remaining in the legacy health scope benefits claims processing system.
Okay. Do you have an update? I know that's only 5 days ago. So do you have an update as of yesterday or today about the total number of claims left?
If you give 1 second, I will check and see if that has come through. I have not yet received that update for today, but I will. Well, I'm sorry. Here it is. It has come through. So there are a total of 714 claims in total inventory.
Okay.
3 of those are dental.
Okay.
And the remaining 711 are medical.
Okay. Okay, that helps. Thank you. So over the course of this discussion, I've heard a couple of things. I've heard that, coding issues were discovered, and certainly, like other members, I've had personal experience. When I came in this morning, one of the members of my staff was actually on the phone with UMR about her dental claim because it was a crown that was coded as orthodontia, so it was denied. And her dentist was fulminating about how he was not going to talk to UMR anymore, so they made her call. So I've heard about peculiarities of the way that a PEB wants their claim management organized, and I've heard coding issues. Have the coding issues been resolved?
Yes, those coding issues have been resolved, which is what has allowed us to expedite the processing of claims of late. Yes.
Okay. One of the other problems was that UMR was showing payments, but providers had not received those payments, had no record of them. I've heard that we've caught up and given a lot of providers the money they were owed. Has that flaw been corrected?
As far as
Darren,
go ahead.
I was going to say, excuse me, Darren. So this is Rhonda Huckabee for the record. And yes, Madam Chair, some of those things are actually related to how the dental providers accept payment. We certainly encourage all of the providers to do the EFT, but some of them choose not to do that. They do their payments through what they call virtual card payments.
Okay.
And some of them actually opt out of that, the virtual card payment and the EFT, and want their payments to be, sent USPS. So certainly that delays some of the things. So a lot of the dental providers, do not want to participate in the EFT. Not sure if it's related to fees that their bank may incur. But we actually did send some of the account management team to several dental offices in Carson City to kind of work with them. And it was discovered it was the way that they were accepting the payments. And because of a large payment, if they do it through their fax, the virtual card payer that they're working with will choose to drop that to paper and send it, via USPS.
Okay.
But that is a lot of the providers that we were made aware of that were having issues, where we showed that the payment had been made 2 weeks ago, but they did not have the actual payment in their office yet. But we worked closely with those providers who did report that issue. And, going forward, we always try to encourage medical and dental providers to enroll into EFT so they, it's a direct deposit right into their account.
Okay. All right. And you guys had mentioned that you sent an email blast out to the dental providers. Did I hear that right?
Yes, ma'am.
Okay.
Once again, this is Rhonda Huckabee. We did work with Diversified Dental because they are the network.
Right.
And they have all of the email addresses for the dental provider community. So we told PEB that we would work directly with Diversified, and they did send out an email blast to the dental community, and then UMR did the same thing for all of the contracted show and UHC providers.
Okay, so the dental providers and the medical providers were all communicated with.
Yes, ma'am. If they were contracted, because
if they're
of course we don't.
Okay.
Yes, ma'am.
Okay. All right. What was the feedback from the providers from the email blast, if any? And are there more communications planned to say, all right, we've got this under control. Please let us know if you guys are experiencing more problems.
Yes, ma'am. So, we work closely with Diversified Dental because a lot of the providers, even though they're the network, not the claims payer, they will reach out directly to Diversified. And we've had that working relationship that we've had with the Diversified team for the last 11 years. So they're very quick to reach out directly to the claims manager or the account management team. And, if they're getting a complaint, we work, with them to assure that the complaints are being addressed. And the same thing applies to the medical community. A lot of the hospitals, just because they've worked with the HealthScope staff for so many years, they have our emails and our phone numbers. So they will either reach out to Laura, or Tim Lindley at PEB, and or directly to the claims manager or myself.
All right. Okay. Thank you very much for that. Okay. It seems like the board has posed all the questions it wants to. Again, this is an information item. So I think I expressed the sense of the board of, disappointment, but I'm looking forward to, I suppose, a deeper dive on looking at our own dental processes, and perhaps this may stimulate some change in the master plan document down the road. So, but yeah, this was deeply unfortunate. And I think UMR, Ms. McClendon, you've raised your hand. Please go ahead.
Thanks. I just want to make a quick comment that we've been talking a lot about the impact on dental providers, and they have been really proactive in reaching out for help. But as we heard in public comment, I think that this has also had an enormous impact on mental health providers. And it's extremely concerning to live in a state that doesn't have enough mental health providers already, that some of them might drop being part of our plan, which would make it even harder for employees of the state to access mental health services. And I know that we're all thinking the same thing. We all have concerns, but I just wanted to make a point that this has a real impact on mental health providers who really rely on a swift reimbursement in order to keep their businesses open. So thanks.
No, thank you for that. That's a good point. Ms. Biddleston.
Thank you, Madam Chair. I forgot to make a comment that I had a second comment and I forgot to make it. I just want to thank Executive Officer Rich, because it seems like she's the one that got the ball rolling with UMR. So, to express the frustration with the board, it shouldn't take Executive Officer Rich's involvement to get UMR to do the right thing and to reach out to providers if there's a problem. But anyway, so I just want to put that on the record and to thank, Laura Rich for that. And I'm glad that we're moving forward. But again, I just don't think it needs, Laura needs to get involved for them to do the right thing. Thank you.
Thank you for that. I appreciate that. I echo the thanks to the executive officer as well as Tim Lindley for the bird dogging they've done on this. Thank you, UMR, for your testimony. And yeah, I think it's only fair that we all own our parts in this. And so if PEB is peculiar, maybe we'll try and be less peculiar moving forward. But anyway, thank you again, everybody. And I think unless there's any more discussion, I will move on to the next agenda item, which is number 7. So we're talking about audits now. And we have Michelle Sukow, I believe, who's going to talk to us about number 7 and number 8. So with that, I will turn it over to you, Ms. Sukow.
Thank you, Madam Chair. Michelle Sukow for the record, MICHELLE, S as in Sam, UCKOW. If you're following along with your packet, this is report number 7. I will be reviewing the executive summary on page 3. What I'm presenting to you today is quarter 3 for fiscal year 2022. The audit period was January 1st, 2022 through March 31st, 2022. This was an audit of HealthScope benefits. During that time period for medical and dental claims, there was just over $53 million paid, 188,118 claims paid, denied, or adjusted. For the health reimbursement arrangement, during that same time period, there was $880,745 in claims paid, and total transactions was 9,828 claims. Our comprehensive audit included an operational review of the performance guarantees, 100% electronic screening with targeted samples, a statistically valid random sample audit, and data analytics. In our auditor's opinion, HealthScope met its financial accuracy measurement for Q3 fiscal year 2022, and no penalty is owed. You can see at the bottom of that page that both financial accuracy and payment accuracy were not only met, but they were actually exceeded with regard to the targeted measure. There were a few findings with regard to the targeted sample, and there was one error with regard to the random sample. And so we do recommend that HealthScope and ultimately now UMR take these findings of this report to determine improvement opportunities to prevent the payments of duplicate claims, payments made outside of timely filing parameters, and just to ensure that the correct co-insurance is applied to claims going forward. All in all, for this quarter, HealthScope performed very well. We are working on the reports for quarter 4 right now, and we've already engaged UMR to kick off quarter 1 fiscal year 2023. Any questions on this report or the summary that I've provided?
Board members, any questions on item 7? Ms. Colleran.
Yes, April Karn for the record. Question,
probably more for Director Rich. On page 17 of the audit report, it does speak to the application of NCCI editing for potential cost savings to the state. I realize this audit was conducted for health scope, but looking forward for UMR or future vendors, have taken into consideration what options we might have around applying those NCCI edits or how they could potentially impact future cost savings?
Laura Rich for the record, we have not looked into it yet, but this is also part of that greater plan to look into, all of the suggestions and recommendations made by not just CTI, our auditors, but our UMR and Siegel, our consultants as well. So we're all getting together as part of this compliance audit and talking through a lot of these things. So I'm sure this is something that is going to be discussed as well.
Any other questions? Okay. Hearing none, I'll accept a motion to accept CTI's audit of health scope.
This is Leslie, so moved.
Thank you. Do I have a second?
This is April, a second.
Thank you. All in favor, say aye.
Aye.
Okay.
Any opposed, say no. Okay, motion carries. And we will move on to the audit of ESI.
Good morning, members of the board. I am Julie Weissman. For the record, it's JULIEWEISSMANN. Today, I'll be reviewing the prescription benefit management audit of Express Scripts. The audit scope was for fiscal year 2021, which was July 1st, 2020 through June 30th, 2021. The components were reviewed in this audit were pricing and fees, reconciliation of pricing guarantees, benefit payment accuracy review, a rebate review, and an overall performance guarantee review. The overall findings for fiscal year 2021 were that ESI did meet the financial accuracy performance standard listed in the contract for the retail guarantee. However, they did not meet it in the mail order guarantee. In aggregate, ESI's overall performance did not meet PEB's contractual financial accuracy guarantee. Pillar X agreed with the ESI calculated underperformance amount of $125,443.43. This penalty was paid back to the PEB on November 12, 2021. The processing accuracy is measured comparing the intended plan benefit as listed in the summary plan description and the claim processed by the PBM. ESI's overall performance in both the retail and mail order met the contractual processing accuracy guarantee. Within each individual guarantee that was met, the retail claim financial was met. ESI reported an overall overperformance of $110,879.21 for the retail financial accuracy, including $110,347.20 for discounts and $532.20 in dispensing fees. The retail processing accuracy guarantee was also met, as noted with 100%. Pillar X noted no errors for retail processing accuracy. The mail order claim financial accuracy guarantee was not met. It was calculated at 95.92%. ESI reported an underperformance of $301,262.59 for the mail order financial accuracy, including $301,000, $262.59 for discounts and $0 for dispensing fees. The mail order claim processing accuracy guarantee was met with no errors. The specialty claim financial accuracy guarantee was met. ESI reported an overall overperformance of $64,939.95 for the specialty financial accuracy. This includes $64,939.95 for discounts, and the dispensing fee accuracy was not included in the guarantee. The specialty claim processing accuracy guarantee was met with no issues. Rebate amount minimum guarantee was met. ESI reported and paid a rebate amount of $14,602,000 $602,000, which is above the PILRX calculated amount of $14,590,240. The rebate remittance time to PEP guarantee was not met. We calculated that as 0% because all 4 quarters of the rebate payments for fiscal year 21 were remitted after the required 90-day time frame. In regards to the claim processing turnaround guarantee for both normal and intervention types of claims, the mail order claims processing time was completed in less than the guaranteed standard number of days. No issues are reported. For the telephone service guarantees, they were met. Customer service telephone response times to answer was less than the guaranteed time, and the telephone abandonment rate was also less than the contracted guarantee amount. It is PILRX's recommendation that the PEB consider removing any offsetting language from their financial accuracy guarantees in their pharmacy benefit contract. For example, if ESI overperformed in any of the current categories and underperformed in separate categories as they have, currently ESI offsets that difference and figures out the net. But using this audit as an example, the PEB would have received an amount of $412,632 in penalties if offsetting was not allowed in their contract instead of just the $125,000. Additionally, PEB should consider updating the performance guarantees around all their financial accuracy dollars to calculate the results based on financial numbers and not just the claim count to make it a little bit easier to calculate the actual percentage rate. That is all I have.
Okay, thank you, Ms. Weissman. I appreciate the report. Board members, questions, comments, thoughts? Mr. Verducci.
It's Tom Verducci for the record. As far as the rebate remittance time to PEB, it appears there were 4 quarterly rebate payments that were missed after the 90-day time frame, causing the performance guarantee not to be met. Is there any plan put in place since all 4 were missed so that could be corrected moving forward?
This is Laura Rich. We have Nancy Langland on from ESI. Nancy, would you just like to give some context to the rebates and the delays in them?
Yeah, sure, Laura. Nancy Langland for the record. I'm the account executive that's assigned to PEB. The reason for the delays were primarily due to staffing challenges that ESI faced during this time period. We have since hired additional staff that have been up-trained, and hopefully we won't experience these delays in the future. But during the time frame in question, that was the main reason why we experienced those delays in payments.
Thank you. And just as a follow-up question, are there any performance penalty guarantees associated with missing the rebate remittance?
So Laura Rich for the record, yes. So that was a, if you look at, and maybe CTI can jump in here and tell me exactly where it is at in their report. But yes, there are, I'm looking at it right now. Julie, do you have it right off the top of your head what that is?
I'm hunting through right now to see exactly what that dollar amount was, or what the difference was.
This is Carrie. The contract, I believe, was 2% of annual admin fees for every percent or fraction thereof below the performance guarantee. Unfortunately, that would be extremely high in this instance since they were 100% missed.
And just a follow-up question: has the performance penalties already been assessed, or is that something that becomes an agenda item in the future?
Well, Rich, for the record, the report from the auditor is presented to the board. Once it is approved by the board, those, unless the board chooses to waive those penalties, the penalties are assessed after the fact. Yes.
Thank you very much.
Okay, Member Kelly has a question.
Thank you, Chair Freed. This is a question for Ms. Rich. I'm just wondering regarding the CTI recommendations to update the penalties or some of the penalties or the language around them. I know that I think we've just entered into a new contract with Express Scripts, right? So I wonder, is there an opportunity to update that language? How will that work? If you can just maybe talk about kind of the process that you follow to implement recommendations such as those that CTI made around the service level agreement.
Sure. So Laura Rich for the record, I actually took a look at the contract after reading these recommendations from the auditors, and the new contract is definitely different. The performance guarantees are not set up in the same way. I think we did a much better job in this new contract, but there's still some, in my opinion, some things that need to be clarified. So it is on my list of things to do to address this with ESI, just so that we can get some of these performance guarantees clarified as to, making sure that these recommendations are incorporated. So we are taking a look at it.
Just a follow-up, Chair Freed. Has ESI indicated whether or not they're open to renegotiating the service level agreement language now? Have you spoken to them about it? Is there anyone here from ESI that might be prepared to answer that question?
Yes, so Nancy Lagland is on from ESI, and that can speak to this. We typically, when we engage in these conversations, as we have in the last contract, they're typically pretty receptive to compromising on making these changes. So Nancy, do you have anything to add on this?
Nancy Langland for the record. I agree with Laura. I mean, anything that's brought forth as a concern, we would happily, negotiate and enter discussions to try and come to, an agreement on how we would proceed moving forward. We also have the annual market checks where, amendments are created for the contract that exists. So there's definitely opportunities to have further discussions on any concerns related to the existing contract.
Okay. I'm not seeing any other questions or comments from the board. Okay. Well, I'll accept a motion to accept this audit of ESI. I'll call on the vice chair. Why don't you make that motion?
Yes, so moved. I'm so moved.
All right, do I have a second?
Betsy, second.
All right, thanks. Okay. All in favor, say aye.
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 Aye. Any opposed? All right, motion carries. Thank you very much, Ms. Langland and Ms. Wiseman. I appreciate that. I'm going to call a 5-minute break before we get into items 9 and 10. It's 10:41. Come back at 10:46, please. And that way everybody can go to the bathroom and get a beverage. Thanks. Okay, everybody, we're back. It is 10:47. Trying to keep this rolling so you guys we can all use our time most efficiently. Let us move to agenda item 9, the executive officer report.
All right, Laura Rich for the record. Let's start with staffing and operations. I know that we've talked a lot about this. I know it is on everybody's radar. We are pleased to announce that we had a small improvement from a 32% vacancy rate up to a 20% vacancy. We're down to a 20% vacancy rate. We have onboarded some new employees to fill 4 of the 11 vacancies. We thought there for a moment we had 5 or 6, but those fell through. So we're down to 4. But it's going to be several months before many of them are fully trained. As you heard, our call center, there's a whole lot of training that goes into that, just because you have to know a lot of information to be able to answer member questions. And so there's a lot that goes into training some of those entry-level staff. We've been lucky because lower call center volume has resulted in improved call center wait times, but the email times the response times for us to get through those emails are still longer than normal. We would love to turn them around pretty quickly within a couple days. That's still not happening. We don't have just the volume of staff that is trained to be able to do that. We have temporarily reinstated a 1-day-a-week walk-in by appointment. We used to have walk-ins prior to the pandemic. We would have walk-ins, available to those members who needed in-person assistance. That stopped during the pandemic. We have since been able to add the 1 day a week. We were not able to do that for a while just because of the staffing. So we have made it by appointment only, just to accommodate those members that need to have that in-person or would like to have the in-person assistance. But if call volumes do increase, so for example, we typically see call volume increasing during the Medicare open enrollment period in October, November, then we're going to have to take those walk-ins away, at least temporarily, until we have the staffing available to do that. A quick budget update. So state agencies, including PEB, were required to submit agency request budgets by the end of August. At the request of the board, PEB did submit 2 budgets which one of them included the reinstatement of all benefits to pre-pandemic levels. Agencies began presenting their respective budgets to the governor's finance office during the September-October months. This allows the GFO staff to ask questions in preparation for the agency request, for how the agency request will eventually become a part of the governor's recommended budget, which is released in mid-January. And I do want to add just a little bit to this, because I know there's been some confusion by public comment. I've heard it in public comment. I've also heard it from board members. So PEB does submit budgets, or we have submitted our budget, in this case 2 budgets, but that is, we don't present it again. We do not present it to the board or in any kind of public setting, because then it becomes part of the governor's recommended budget, right? So then the governor and the governor's staff make whatever changes that they deem are necessary to that budget, and then it makes it into the overall governor's recommended budget, which is then presented publicly. This is all confidential until it is presented publicly in the middle of January. At that point, then it is handed off to the legislature, and the legislature gets to review those budgets. And eventually, sometime, usually it's around April or May, the PEB budget is heard, and at that point, legislators have the flexibility to make changes to the budget that was submitted. So there's a whole lot of steps in that, and every step of the way there is an option to potentially, or changes that can be made. So speaking of the legislature, the 2023 legislative session is scheduled to begin on February 6, 2023. PEB has already started to track bill draft requests, or BDRs, as they get posted. To date, 90 of the 446 posted, I think there's a little bit more now, have been identified as bills impacting healthcare or issues that may have an impact on the agency in general. So right now, there's not a whole lot of language that is released. The BDR will say something like changes to healthcare, or this bill, this BDR makes changes to health insurance, right? So we don't know anything more than that. So that's what we're tracking at this time. Once that language comes out, I hope that the 90 that we're tracking will start to dwindle. However, we do anticipate a large volume of healthcare related bills, and we expect to be very busy this legislative session. Not just healthcare related bills, but obviously we've got a large or a very significant challenge with staffing. And so I think that compensation and benefits are going to be under the microscope. And so I think that we're going to have a whole lot to do in that space as well. So as we have done previously, monthly board meetings will be scheduled between February and May of 2023 to provide the board with an opportunity to discuss and weigh in on any proposed legislation. Another thing that we've been working on is office relocation. So throughout the last several years, there's been some talk about possibly PEB moving out of the Bryan building to provide the much needed space for the Department of Conservation and Natural Resources, which is DCNR. But recently, the Division of Emergency Management, DEM, indicated that they needed to expand their space in order to meet their own federal requirements. DEM shares a space with the Division of Forestry. So in order for DEM to expand, NDF has to move. It makes most sense for NDF to take the space here in the Bryan building because they belong to DCNR. It allows them to have all of their divisions housed in the same place. So as we've been working through this, it was discussed that that PEB would be willing to move. These discussions have included the governor's office as well. So we've been looking for a new office space, which has been actually more challenging than I expected, especially in Carson City, so that will accommodate the agency's needs. But the timing of this is highly contingent on necessary IT equipment, which unfortunately is on back order. We think we're going to be able to get this in time for a February move, but that is still all up in the air. I would personally appreciate moving either before February or after July, because that is when PEB is most busy, right? And we also have the legislative session and things like that. So if we can make it happen before February, that would probably be the best. If not, we probably have to push it out until July. So that's just to avoid any disruptions and allow us to be ready for open enrollment and get through open enrollment and through the legislative session. A couple things that I wanted to add that are not on this report. I've got a few of them. So I've talked a little bit about the compliance already. We are in the process of doing that compliance review. We addressed it at, I can't remember if it was the last month board meeting or the meeting before that, but it did come up. We are presenting this in two different buckets because we have gone down that road of doing that deep dive of just going through the MPDs and how we're paying our claims and things like that, and what makes sense. Some of these equity type scenarios we heard about, the hormone therapy and things like that. What are we doing that's non-standard? What do we have that's outdated, right? The potentially the $1,500 dental max may be too low. So these are all things that we are considering and will be part of that, the overall recommendation that's brought to you in January. We expect actually it would be the November board meeting, but that's been pushed out to December 5th. So at the December board meeting will have what the board is used to seeing, that compliance portion of whether we are in compliance with federal and state regulations. So that should be presented in December. Additionally, I wanted to bring up the Patient Protection Commission cost growth benchmark project. We are still working with the PPC on that, and I just wanted to make the board aware that these discussions are happening, and there's lots of potential involvement in the future with PEB as a result of this. So I would encourage board members to to watch these board meetings or the commission meetings, but in the future I will be providing updates on that. Additionally, I just wanted to provide a quick update that PEB has been offering the flu shot clinics again. We did put on a flu shot clinic here in Carson City and also in Las Vegas on September 19th. We have a follow-up in Carson on October 13th and a follow-up in Las Vegas on October 10th. We're also working with the University of Nevada, Reno to potentially schedule something on campus there as well. The great thing about these flu shot clinics this year is that not only are we offering flu shots, but we're also offering COVID vaccines and then also shingles vaccines as well for those who qualify. So I'm super happy about that, and we're getting a lot of participation in that. So with that, I'll take any questions.
Questions, anybody? Mr. Verducci.
Yes, Tom Verducci for the record, and thank you so much for the report, Officer Rich. Appreciate all the information, and I just had two items I wanted to bring up. I noticed that we have two budgets that have been submitted, and then they have to go through the GFO and the legislature. And my question is, how does that impact item 10 here on the agenda in terms of plan design changes? Have we already submitted plan design changes that are in the form of a budget, and now we're waiting for them to be approved, denied, or altered? Trying to just see what the difference is between what we're going to be voting on item 10 and what has already been submitted. That was my first question.
Okay, so Laura Rich for the record. So what was submitted was, or let me back up, the direction by the governor's finance office was for state agencies to submit flat budgets. So that means whatever their budget cap was last biennium would be similar this biennium, right? PEB got an exception to that. PEB was able to submit a budget that where we could increase the actual dollar budget based on what the current benefit levels are to maintain. So that budget that we submitted is based on keeping everything the same and not adding any additional costs. So that was the direction of GFO. Now, the board also asked PEB staff to submit an additional budget request that provided the restoration of all of the benefits that were cut during the pandemic. So we did that as well. We won't know if we are going to, if PEB is going to get any additional funding to fund any kind of programs. We won't know that until the governor's recommended budget is released in January. So there's going to be, I can tell you right now, there's going to be a whole lot of discussion. There's already a working group that has been formed to address compensation and benefits. And so there's a potential that, there could be money allocated to PEB, but at this point, that's not what we're working with. We are working under the direction that we're keeping benefits the same, or at least the funding that we're using is to keep benefits the same. We're not using any new funding to increase benefits or to add additional products or services.
And just as a follow-up, since this budget has already been submitted, 2 of them, does this require another action on behalf of the board on action item number 10, agenda item number 10? Trying to figure out if
No.
we've already.
So Laura Rich, for the record, no, at this point, agenda item number 10 is talking about what kind of things that we can do with what we have today, right? So this is not adding any new money. It is working with the current budget we have today under we do have some excess. So we'll talk about that during that agenda item. So we do have some excess. So we do have some money to spend. It's not very much, but that is still working within the budget that we have in the budget guidelines that we were given by the governor's finance office.
Thank you so much for the clarification. And the second part of my question, I was curious how the Patient Protection Commission discussion that we had really affects PEP. Kind of, how does it actually affect PEP? I'm trying to put the two together.
So Laura Rich, for the record. So in the cost growth benchmark project, basically we've got Medicaid who is submitting their claims data and PEP. And so we're all submitting claims data to present and for the commission to discuss and potentially look at ways to, the goal here is to slow or curb the cost of healthcare, right? So healthcare is increasing, the cost of healthcare is increasing dramatically. And so they're looking at ways to decrease the cost of healthcare. Without data, it's difficult to be able to do that. And so you've got Medicaid and PEP as state agencies. We're providing that data because you've got the commercial market who isn't required to provide that data. And so PEP is being used as a proxy to the commercial market. There's potentially some recommendations and decisions that could be made, to use PEB as and this would probably, end up at the legislature, the governor or the legislature would likely be weighing in on these types of suggestions of, if there's any kind of changes that can be made as, maybe a pilot program to see if there's ideas that can impact the growth of healthcare costs, right? Or to at least slow them. And so sometimes what comes out of these types of projects and analysis is ways to use state agencies as a test, right? How do we pilot this to see if it works? So that's just something that potentially could come out of it. But right now it's really just, it's presenting data and looking at that data to see if there's, what areas in the state are impacted by these costs and where can we focus our efforts as a state, not just as PEP, but as a state to lower the cost of healthcare.
Thank you so much. And I see another hand up. I want to just throw out one more question real quick. Where are you guys looking at moving to? I mean, it makes sense with conservation moving into the Bryan building, but has there been a location determined at this point?
Well, Rich, for the record, there is no location determined. We do have it narrowed to, we think, one location. It is in Carson City, but there's nothing concrete or in place yet. We're still working on that, and we hope to have something. We're working really hard to get it wrapped up, because we want to make sure that if we're going to move, we move before February.
Well, thank you for all you do. It's much appreciated.
Member Kelly, you had a question.
Thank you, Jeffrey. I just wanted to find out more about the benefit and compensation working group that Ms. Rich mentioned. I wanted to understand kind of what level that working group is at and who's on it, if the PEB board's on it, if you could share more about that kind of organization and how I guess we can influence that.
Laura Rich for the record. This is really just something that the governor's office is looking to get information and data from different agencies within the state, just so that they can better make better decisions, as they formulate that governor's recommended budget. So there's not a whole lot I can share right now on it, other than, we know that the governor's office, this is high on the priority list of the governor's office. They are looking to get as much information as possible. And this is something they're very, very concerned about.
Board members, other questions? Okay. Thank you, by the way, Laura, for clarifying that you haven't settled on a place to move to, because I was going to ask if the fiscal impact is going to merit a IFC level work program, since the square foot, it's $1 a square foot basically for B&G rent, but it's $2 something for commercial rent. So a question on the budget. Has PEB had its budget conference with the governor's finance office yet?
Laura Rich for the record, no. And the reason we have not, and we actually had to clarify, because normally you put together a formal presentation and you present it to the governor's office, because of where we are and the focus on pay and benefits. I think we're last. And it is, it's not really a formal presentation. It's more of a discussion. Yeah. So we have not gotten to that point yet.
Okay. Yeah, I'm going to be interested to see how everyone in that conference reacts to the budget with the subsidies, like the so-called flat budget with the subsidies being allowed to grow, as opposed to the second budget where the board restores the plan design to very nearly what it was pre-pandemic, and what the reaction is. So thank you for that. And I think that's the only question I had. And so with that, this is an info item, so we can move on to the next item, which is an action item, if everybody is okay with that. Looks like yes. All right, let's go to agenda item 10, discussion and possible direction from the board to staff on potential program design changes for plan year 24.
So Laura Rich for the record, repeating myself again, but it's the PEB's final FY 24-25 budget will remain unknown until it is approved by the legislature in the spring of 2023. We've submitted our budget based on the governor's office directives, and it was built to fund the program at current benefit levels for the biennium. The second budget, at the direction of the board, was built to fund the program at pre-pandemic levels. So I just want to make clear, since PEB is already using our excess that we got as a result of the claim suppression during the pandemic, we're using that cash to restore many of the benefits that were cut as a result of the pandemic. So most of those benefits are already restored, with the exception of maybe life insurance and long-term disability insurance. So, but the benefit portions themselves, the health insurance benefit portions, have been largely restored. As shown in the table below, because we were very interested to see, well, I'm sorry, I'm getting ahead of myself here. So as shown in the table below, PEB is starting off the current fiscal year with a beginning differential cash or excess cash balance of $33 million. But after we factor in all of what has already been earmarked, right? So that is the plan design spend down, that's the restoration of those benefits, and then the premium buy down. If you recall, during the last budget cycle, we used a little bit of excess to bring down some of those the premiums in the second year of the biennium. And then additionally, the Medicare HRA and things like that. So after all of that has been earmarked is removed from that $33 million, we're left with about $9.5 million in excess cash that can be allocated towards new benefits, incentives, or other enhancements. It's not a lot. $9.5 million in a $1 billion budget is not really all that much. So not all benefit enhancements will require the use of funds. Some of them, well, most benefit enhancements come with a cost, right? So you're adding a benefit of some sort, whether it's a product or service, or you're increasing or decreasing deductibles or something like that. There are some things that we can introduce that are cost neutral or even result in an overall net savings. So for example, the implementation of a chronic disease or weight loss program may result in an overall reduction in claims or reduced increases in claims. So the ROI, or the return on investment, though, is sometimes hard to prove. And if we do miss it, it could require PEB to dip into catastrophic reserves to make up for those budgetary differences. So we thought that this was something that was necessary, not just for this discussion, but moving forward in terms of, in the legislature, and as we start these discussions, with the governor's office and things like that. So obviously we've been plagued by staffing shortages, not just PEB, but every other state agency. And it's been argued that the state is not competitive in wages or benefits when compared to the private sector and other public employers in Nevada. So as a result, we thought it was important to understand how we compare. How do PEB benefits compare? So that we can look to see, where should we improve? What are other public employers offering that we're not? And what do they do that PEB does not? So we did our best to, it's very difficult. I'm just going to say that right now. It's very difficult to compare apples to apples, but we did our best to put together a side-by-side comparison here of the different plans. We looked at Washoe County. Unfortunately, Clark County does not make employee benefits publicly available. We've asked for that data. We have not received it. There's Chair Freed pointed out that there is a error here. It does not in that chart. I should say does not. It's missing the word not. We also compared City of Sparks, City of Las Vegas. We have 2019 data, so it's a little bit antiquated. We've asked for new information on that. Clark County School District, Lyon County School District, and Carson City School District. Basically what you can see from this, oh, and let me just add, there's one glaring one that's missing, which is City of Reno. The reason that was not included is because City of Reno has a handful of collective bargaining agreements, and everybody gets, from my understanding, everybody gets different benefits. And so it was difficult to use that as a comparison. So by looking at these, you can see that PEB is actually not that, we're pretty competitive, right? We're pretty competitive. We've just chosen, the state has chosen to focus its efforts to not just the employee, but the family and also the retiree. Whereas a lot of other cities, counties, public employers, they focus on, if you look at this chart on attachment A, they focus on the employees. So you can see that most of these employees, the active employee they have $0 premiums. But once you get into adding family members, it becomes very expensive because they don't subsidize the families quite as highly as they would, the employee. Whereas the state, we kind of spread out that cost, right? We don't give an employee a $0 premium, but we do provide pretty decent subsidies for families. The other thing we do too that differentiates us from those other public employers in the state is the way that we treat retirees. So retirees that retire from the state of Nevada do get pretty good benefits when compared to other employers, right? So they get a premium subsidy. So their overall premium is to start with lower, and then they get a years of service subsidy as well. So they based on however long they've worked, they can reduce that. Other employers throughout the state do not provide that. They either provide a very small years of service subsidy, or like, for example, City of Sparks, it depends on the collective bargaining agreement, but they can use their sick leave to be converted into a subsidy. But once that sick leave is depleted, then those premiums, go back up again. So, I thought this was interesting because we are actually pretty competitive in the grand scheme of things. It just depends on how you want to look at, do we want to focus on the family, or do we want to focus on the employee, or do we want to focus on actives versus retirees? The state does a pretty good job of spreading it out, whereas a lot of these other public employers do not. They focus on their active employees. So with that, on the initiatives, earlier this year, PEB staff, several board members, and vendors met in a day-long strategic planning session. Thank you for to the board members that did participate in that. Each partner provided valuable input on plan performance and possible solutions that may be beneficial to plan performance. So basically, what we're proposing here is a series of programs that either come with a cost or can be pitched as a potential cost neutral situation. This is not an all-inclusive list. This is what staff is coming to the board saying, hey, this is what we've come up with. These are things that I think warrant some additional analysis to bring back at the December 5th meeting. But if there's anything else that the board would like to add to this list, we are certainly willing to add to this. If there's something that is on this list that the board has no appetite in pursuing, then this is the time to discuss it, because there's no point in doing the analysis if this is something that there's no appetite for. So the list here starts out with real appeal. I'm just going to go over just high level of some of these things that we're proposing to bring to the board in December. Real Appeal is a virtual weight loss program. You're going to hear a lot about these. This is new, that's coming out, a lot of virtual programs, especially after the pandemic. People are a lot more receptive to virtual solutions. So there's no per member per month fees. These are just paid through claims. It's a small, I think it's a $49 claim for every member that is participating in this per month, and it's just a claim. And really, it's a program that kind of gives you those people that meet the requirements of this program. They get all kinds of cool little gadgets and a scale and things like that. And there's some monthly encouragement to reach their weight loss goals. Why this is important is, obesity is associated with most chronic conditions, including diabetes and hypertension and heart disease. So launching an option that assists with weight loss and weight management may help reduce costs in other areas. Hinge Health. So this is a virtual musculoskeletal, I cannot say that word, so I'm going to say MSK clinic and therapy program to address chronic knee, back, neck, hip, and shoulder pain. I have heard through other states, other cities, and basically other programs who are offering this, lots and lots of good feedback. This is something that there's a lot of members. MSK is a high cost claims in the program, right? So this is one of the highest costs in the PEB program and really, nationally. It does come with a PMPM cost. That PMPM cost, I would say there's a good chance that we can argue that would end up being cost neutral. It does replace in-person, or it can replace in-person physical therapy, and you'll probably be hearing me talk about access issues here. We've already talked about them, but you'll hear me talk about them more based on what is happening at PEB. But it's hard. It's hard to get into physical therapists right now. And so if there is a virtual option that is, that's been, members seem to be, the members that are using it through other programs are very, very happy with. There seems to be a lot of very positive feedback about this program. This is something that, we could look at it and do the analysis, but I have a feeling it would come back as a cost neutral type situation. It would provide greater access, but also it can help reduce overall MSK related claims costs. Cancer concierge. So this is really a concierge service that assists the member basically to navigate a critical and stressful situation. The programs assist patients by making medical appointments, coordinating care among all the different providers, providing coaching, and assisting with the billing and claim submissions. Generally, when someone is undergoing cancer care, there's a whole lot going on in their life, right? It gets not only on the medical side, but on just the billing and the finances and keeping track of everything it's a lot of work. And cancer is the #1 cost driver in the program. So patients that are diagnosed with cancer just often do have very complicated medical situations and complex billing scenarios. This is probably not going to be a cost neutral type situation. This is going to come with a PMPM cost, but I wanted to bring it up because, I hope I'm going to bring up an example. I think that many of you remember our former board member, Jet, who passed away from cancer. I remember when she went into hospice, I called her and I asked her, if there was anything I can do for her. Her request of me was to help her partner navigate through all her bills after she was gone. And to me, that was just, no one should have to say that as they're preparing for death, and so this is, if we go down this path, it's a service that we're going to offer people who are going through very complex situations that need that assistance. And it's the empathy and, and just the hand-holding that they need through this already difficult process. So, I think it's something that we should consider, and something that I think would be helpful to the patients or the members on our program who are faced with these situations. Next one is medical travel. These programs provide access to a network of specialists for generally high-cost surgical procedures. So we already kind of do this anyway. We do this where we've got hip and knee surgeries, for example, right? We have reference-based pricing for hip and knee surgery. So we basically say, these are the facilities where you need to have your hip and knee surgery performed. If you don't have it performed, we are only going to pay, or if you don't have it performed at any of these facilities, we're only going to pay what we would have paid that facility. And the reason we do that is because, for example, if you have a hip or knee replacement in Elko, the plan can pay upwards of $100,000, whereas that same procedure in Reno would be $20,000, right? And so what we do is we pay for the travel for that member and a companion to come and have their procedures done at a high quality, low cost facility. This just expands on this. The medical travel expands on this and really just produces lower cost and improved outcomes. This also would come with a PMPM cost, and an analysis would be necessary to see if that is something that would be eventually would be cost neutral or would come at a cost. Premium credits, that's another way. We've got $9.5 million. We could utilize that cash to provide premium credits. Premium credits provide immediate financial impacts to members. So it is it's a way to spend down those reserves. Also, doctor on demand. You've heard mental health it's a problem. We've got mental health shortages all over the nation, but definitely the North and more so even in the rurals, we have a major shortage of behavioral health providers. And so people do not have access. And I mean, I'll give you an example. In early July, I had a hospital, actually it was a provider in Northern Nevada who reached out to me. Multiple providers actually reached out to me with the same scenario, saying, hey, look, we've got 100 people that we service and we are out of network in this new network that you guys have. What do you want us to do? And so the first thing I had to do was call our network and say, hey, you have to contract with this provider, because there is no way we've got 100 people on PEB that they service and they cannot, they don't have anywhere to go. You know, that there's waiting lists of months and months long. And if you need a psychiatrist, that's upwards of a year. So there's already a drastic shortage in behavioral health providers. And we have the doctor on demand option where it's not just your typical kind of urgent care type service that you would use doctor on demand, but there's also the behavioral health component too. There's not a whole lot of utilization in that behavioral health. And so potentially we can work to incentivize that so that people can start using this type of service for their behavioral health needs. So that's an idea as well. And then the last one is the elimination of the EPO plan. So the EPO plan was developed to replace the fully insured HMO plan previously offered by Hometown Health in the North. And it was intended to mirror the fully insured HMO plan offered by HPN in the South. The problem with this plan is that it is not just administratively burdensome for the staff, but very burdensome on the members as well. Because what's happening is you've got, it's a regional plan, right? And so there are no out-of-network benefits. You must remain in network and seek services in network. So members on the EPO plan, typically you would choose an EPO because because it's got the actuarial value is higher, right? So you're getting more benefits, right? So more richer benefits through the EPO. Now those premiums are also more costly as well. So typically you get those people who utilize healthcare. So they're the ones who are going to the doctor. They're the ones who are probably seeking services because they've got conditions that require those higher cost services. So we already have a sicker population on this plan. Those members likely are seeking services that are not available in Northern Nevada. We have a very significant shortage of providers in Northern Nevada. And typically, if you've got specialized care, you have to seek services outside of Northern Nevada. So what's happening here is that anytime that a member on this plan has to seek a service outside of the network, it becomes an exception. It becomes we've got to get this approved. We have to look at, are there any other providers? It's an administrative burden on staff, not just internally at PEB, but also through our vendors. It's very manual. And then also it's a pain. It's a pain for members as well. The other problem is that members don't necessarily recognize that this is a regional plan and that there are no out-of-network benefits. So you have a member who signs up for the EPO, and they don't realize that their college-age kid who is out of state somewhere going to college, who they cover on their plan, does not have access to healthcare outside of urgent and emergent type situations. And so those dependents that are outside of the state don't get to seek care. And by the time they realize this, they're 3-4 months into the plan, right? And so it becomes problematic. And so really it's something that we may want to consider moving forward, just because of the scenarios, the access scenarios in the north versus the south. Although I do fully recognize the fact that the northern members would have one less option when compared to those members in the south. So with that, PEB recommends that the board approve the research of some or all of the above proposed Plan Year 24 program initiatives, as well as any others that are not listed in this report. So I'll open it up for discussion.
Okay, thank you for that. Okay, I've got lots of people jumping in, raising their hand, but Michelle Kelly has had her hand up for quite a while, so I'll let you go first.
Thank you. I'm not sure if it's ever really good to go first, but I put my hand up as soon as I had my first question. So I do have a few questions. So I appreciate your patience with me. So the first question is, I guess probably all the questions are for Ms. Rich, but I wanted to, I've been reviewing attachment A, so the comparison of PEB to kind of our city and county counterparts in public employment. And the first thing, I think, honestly, I pay a lot of attention to this because it is publicly available and it kind of is a summary of our benefits. And so I think it needs to be correct, including the PEB stuff. So my question is around the retiree subsidy line initially that you've got here. You've indicated that PEB pays a premium subsidy for employee and family tiers and a years of service subsidy. And I just wanted to ask you about that because it's my understanding that PEBP no longer subsidizes any retiree health insurance for new employees. And in fact, any new employee hired on or after July 1st of 2012. So when I review this, I think it's not correct, because for the last 10 years, we've not been providing a subsidy. So yes, we do have a grandfathered population, and I understand that, but anyone new coming in, we're not budgeting or providing any cost savings for them as far as their retiree health insurance. And I see that, you know, the city of Las Vegas, Clark County School, there's no subsidy listed for any of them. And so I think that either you need to go into detail here for PEB, because I'm guessing that some of these employees in these groups may have access to an old subsidy as well. I don't know that, but I certainly don't agree that PEB or state of Nevada employees have an option for retiree health insurance anymore. So that's my first comment on that particular sheet. And I look forward, I wonder if we should also be looking at our neighboring states, neighboring state employees such as Utah, Arizona, because they probably fall within our catchment area as well, and they're larger employers. I've got no idea what their benefits look like, but I think it would be interesting to see if that was possible. So that's my first question. My second question is this list of services or programs that you put together is really interesting, and I appreciate you putting together this. But I do wonder how, as a committee, how can we measure their effectiveness? Like, not just from a budgeting perspective, you know, that's obviously really important, but also just from an participant uptake and reviews, I guess. You know, like, I mean, I do not buy one thing anymore that I have not read extensive reviews on, kind of understand the trends of the service. What do people think of the service? And I know that we already have some services that I think some of us scratch our head and wonder why they're not more broadly used by our population. And so as we look at adding new programs, it would be really good to understand how can, as a board member, I go out and actually see what participants think of these services and, you know, how they review them, as well as the budget impacts. Because if something's poorly reviewed and people really don't like it who are already using it, why would we add it, is my thought there. Third question, and specifically looking at the cancer concierge, that's the one that actually sparked this question for me. How would the cancer concierge service interact with the pre-approval processes that we already have in the plan, right? Because it's my understanding those pre-approval processes provide a nurse that then outreaches people to make sure that they're kind of seeking their services and they're getting their medication and they're taking it. So how would a program like Cancer Concierge intertwine with that? And is there a concern that we're raising, that we're making it more complicated for our participants, I guess, when the intent, of course, is to make it, streamline it, make it easier, provide them more services? So are we just adding more and more bureaucracy so that these things are just too hard to find or to use? And then just to comment on the medical travel piece, I appreciate that there's lots of savings around medical travel, potential savings, not to mention just better service. My concern with expanding this and potentially offering it for more conditions is that there are some conditions where people need to be, there's some reasons why people need to be in their home city to have things done. If you're a primary caregiver for a family member, maybe you need the support of your children while you're recuperating, but this program only allows for one person to go with you and, and see you through your services. So I have concerns about kind of broadening that until we can understand the impact it will have on a person's recuperation, because a lot of people need a lot of support, especially for these more serious medical conditions. And with that, I appreciate your patience, Chair Freed. I will cede the floor.
Okay. Now, are those questions you'd like to have the staff address to the extent they can now, or are those research questions to bring back answers to?
I think if they have the answers to those questions now, that would be great. But and if they need to research them, if they can just indicate that they'll bring it back to us in December, maybe, or prior to that.
Okay. Laura?
Okay, so I'm going to start. I know you had 4 of them. I don't know if I can remember all of them. I'm going to try. So the first one, you're correct. I will update that table just to asterisk the after 2010. This is no longer a benefit. So I will definitely update that. The second one you had asked, how do we get feedback? You know, unfortunately, the way we gauge feedback is on the negative, right? If you hear a whole lot of noise about how someone just doesn't like something, and typically people don't provide feedback when they like something. They only provide feedback when they don't like something. And so that has been really how we've gauged, you know, the satisfaction in the past. Another thing we've done is put out surveys, right? So we have attempted to put out surveys. We haven't done it recently just because of, you know, the complexity of the pandemic and all of these, you know, different vendor changes and things like that. So we haven't put out a survey recently, but that's something that we can do is say, you know, have you used Doctor on Demand? Is this something that you like? So it's definitely an option. We can put together something moving forward to see if, you know, how people feel about certain things. My thought is that a lot of people just don't know about it. They don't know about some of these options. And as much as we have tried to push it in different ways, we've tried to communicate it in our newsletters, we've done mailings, we've done, you know, there's different ways. There's still people that just don't read. They see something that comes from PEB and they throw it away, right? And so there's definitely some issues there, you know, with the communication. And if anyone can solve that problem, I thank them forever and ever, because it's definitely something that we struggle with internally at PEB, is that communication and getting people to read and getting people to understand what is offered through the PEB program.
Can I just interject, Laura?
Sure.
I'm sorry, I just wanted to clarify. So I appreciate that about the service we already have in the plan, but what about before we go out? Do you reference check? Do you go out to other organizations that offer these benefits and kind of ask the executive officers of those plans, hey, how is this working? What's the uptake? Can we do some of that pre-work, at least on the per member per month cost programs? Have you already done that? You know, will you do that? How do we, at least for before we add them to the plan?
So specifically on Hinge Health, yes, I've spoken to the state of Alaska who's been using them, and the state of Alaska has a lot of the same problems that we have in terms of access, right? So yes, this is where I'm getting, not just through the state of Alaska, but also I've gone to conferences as well, where there's, you know, a lot of people out there who are attesting that, hey, there's, you know, our people, our members are very, very happy with X service or Y service, right? And so we do, before I'm bringing this to the board, there is a level of research that we've already done. Now, again, you know, if there's no appetite in this, we didn't want to go down the road of doing all the analysis and all that, which is why we're bringing it today to the board, because we don't want to do a lot of that work, you know, for something that there's no appetite for. But yes, for Hinge Health specifically, we have looked at that. I have not looked at the cancer concierge or medical travel. Real Appeal is already used for members on the HMO, already have that. And so this would actually be adding it to our other plans as well. And then the last question I think you had was, and I'm going to have to call on some of our vendor partners for this, either Richard Ward or Nathan or Rhonda from UMR on that last question about how does Cancer Concierge work with and integrate with the TPA and UMCM and all those different components of the plan.
not sure if I should go first or not.
Go for it, Richard.
All right. So generally, just speaking from an industry, general industry perspective, these focus programs or point solutions provide services in addition to or broader services than what the carriers or the TPA provided programs provide. So in particular with Cancer Concierge, it would be, Laura was mentioning, assistance with billing. And from a true concierge perspective, assisting with other personal needs, or some of them do, personal care needs. So you may need help keeping your house clean, or other personal needs. I know I keep using that term, but that's a common additional component compared to programs that are provided by the carriers or the TPA that are more medical care focused.
This is Laura Freed. So relating this back to our late colleague, Jet, she had complicated, or what do they call it, large case management through our vendor that does that. And this would be broader than just medical RX care coordination that we already have a contract for.
Right. There's a range of how these programs are structured. Some are more focused on the care coordination and come with a center of excellence component to their program. Others focus on coordinating care locally, and then others add to it the more personal needs component of things.
Thank you very much. I see, oh boy, this caused people to put up their hands, and I've been trying to patiently go in order. I feel like Ms. McClendon was next in line to pose a question. I don't know if it's about Cancer Concierge or something else, but please feel free. Go ahead.
I just wanted to see if we could, I was looking at the travel options, and I was thinking about how many states are now making abortion fully illegal. So if we have people on our plan who live in other states, is there a way that we could look into the cost of covering transportation for them to get to a state where they could get a medically necessary abortion? Is that possible?
That is certainly possible. We do have dependents who potentially reside in some of these states where abortion care is not available. And so they would have to travel elsewhere. For example, you've got we have members that have children who are going to college in Utah, where it is, that is not something that would be available to them. They would have to travel outside the state. It's something that we can look into for sure and can add to this analysis as well.
Thank you.
Okay, I think member Ayala was next.
I have a few questions, but in regards to Cancer Concierge, I thought I'd jump in a little bit. Right now, I'm dealing with a sister-in-law that has lung cancer and potential colon cancer, and she was going through chemo with the oncologist, and they said she needs to get a GI, and they sent a referral, and the company said, well, we can see you in 3 months. And it's like, no, this person has stage 4 cancer and may be dying. And they're like, well, you can call us every single day and see if there's a cancellation. And her GI sent another her oncologist, and it still didn't work, but their staff won't sit there and try to make all the appointments for you. So there's another GI group in town. Somehow, after waiting already 6 weeks, we finally got into that. And then that found something, and there was supposed to be a follow-up through them that was having problems getting scheduled. So then there was an ER visit with C. diff. And so then that stopped something else. So then there was a referral to a regular surgeon that probably didn't need to be met because people were not, the docs, even though they send reports back and forth, they weren't getting to read exactly what the other guy needed to do. And so I just have to tell you that someone that would help make appointments and the saying coordinating care among multiple providers. There was even a prep for a colonoscopy that then the colonoscopy got called off because of the C. diff that hadn't gotten noted, even though we had called them and let them know. I mean, it's been a nightmare, and to have somebody, even though there is case management on our insurance plan, it really isn't to that level. So just bringing that up from something I'm currently going through with someone, I could see where that could be a lifesaver for this person and even the stuff I'm doing. So just on the side, I wanted to bring up some of the same things. My history, having worked in insurance programs, are that there were many plans that vendors and folks had brought to us that said, this is what's being done, and it's going to save you all this money and do better care. And we would implement the programs and nothing would happen. You know, you wouldn't save money or nobody would take it up. And so the same thing, if we could find actual entities instead of the people that provide the programs, but entities like Alaska or whatever, when you're doing the research that are saying, yes, people like this, they'll take it up. This is the way to communicate it. This is the way to outreach it, so that there's a little bit more than just starting the program. And so that was similar to Michelle Kelly, member Kelly's comment, that I think that we need data on the success of these programs and what made it successful, if there's a state that has made it successful, because that may be the key, the what. And then another comment I had was, in our comparisons, one of the big griefs I've had, just worry, is the elimination of the long-term disability that we had to do, since we don't have people on Social Security. So they can't get Social Security disability and our life insurance. And I know that you guys did a comparison of the medical, but I don't see that. And I think it would be good to see that. And if they don't have long-term disability, are the entities, because I do know some public employees do get Social Security, so they can get Social Security disability also. So is there access to disability? Because that for me might make a difference, not just the health insurance plan, but a couple of the other benefits in choosing if I had multiple offers from different public employers. And then I have one more comment. So I don't really need anyone to answer back. They're just comments I want to put on record, I guess. And from what we've heard in public comment, and it sounds like the public that's at least interacting with us are not really supportive of the elimination of the EPO. And if one of the biggest issues with it is no coverage on out of area network, maybe we can make that more obvious before someone chooses it, like a big red, if you choose this, these are the benefits, but no out of network coverage or something. Just a thought, because we had a lot of public comment on it. And that's my comments on what we've heard, though I tend to think all of these things sound really good. I just hope they really are.
Okay, thank you. I want to note on the LTD that executive branch employees enrolled in PEB get disability from PERS. So the LTD elimination mostly affects NSHE professional employees. We had discussed that when we were talking about reducing the budget in advance of the 21 session. And this came up, the legislature posed this question to PEB staff during the 21 session and wanted to know how many people that would be. So it turns out to be NSHE basically. So with that, I'll go to Vice Chair Barnes.
Yes, thank you. I have a question for Laura Rich, please. And I just wanted to clarify that, am I correct that the state is not providing retiree healthcare benefits for post-2011 hires?
Yeah, so that is correct. So after post or 2012, that is completely eliminated.
Okay, thank you. I just wanted to be sure I was right about that. Thank you.
All right, with that, I will go to Member Woodward.
Looks like you're on mute.
I'm so sorry. Gosh. I'm having a day or a week. I wanted to just give a comment regarding the cancer concierge from a personal experience. Obviously, I've not had the cancer concierge itself through any of our current stuff, but in the past, I took advantage of that through some of our previous coverage. And it made a huge difference when my case was of advanced cancer, breast cancer was dropped by my provider. It kind of fell through the cracks. And I ended up technically outside of the chemotherapy window. Of course, I was pretty livid about that, and I contacted my provider. And through the provider, the nurse provider, through our previous coverage that we had, was able to get me in really quickly with another oncologist in town and kind of facilitate a lot of that stuff. And there were a lot of things that person was able to do for me. So that means a lot to somebody going through that cancer experience, the treatment and everything that is included in that. It takes some of that stress off. And, I can sympathize with or empathize, I guess, with Laura, your conversation with the previous board member who went through that, because it's a huge difference in having somebody even on your side. I did not need to take advantage of some of the things that they could do, but I could for important things like getting in for a needed procedure or a test, or getting in with a doctor's office. So it was very helpful, and I just want to put that out there from my experience that's a great thing to have.
Thank you. Member Biddleston.
Thank you, Madam Chair. Just a few comments. I do want to thank Laura Rich and her staff for the background research that they've already done in presenting this information to us. I am a longtime state employee, and I started at the time where health benefits to the employee was zero. So I do remember that. And that was one of the reasons to come from the state. I had just left the Army at the time, and so military benefits are free and nothing like anyway. So I just kind of wanted to say that I think that for members, looking at lowering the cost of any premiums would always be great. Secondly, I want to talk about the cancer concierge. I don't even know if I said that right. I did lose my father, who was a state employee, to cancer several years back. And one of the things that I found very, very difficult to deal with after his death were all of the bills that I was getting from the various doctors. Because when you're on the PPO, every single doctor, every single anesthesiologist, every single this, every single that bills separately. And so I would really, really like to say that what Laura mentioned with the individual that that she talked about is absolutely true. I was getting bills for 2 years after his death. And it's so confusing. You know, you don't know if you've paid the bill before. So I would also like to say helping family members get through this. You know, I was a state employee. My father was a state employee. So, you know, I just really want to say that that would be very beneficial to families. So thank you for the opportunity for comments.
Thank you. Member Verducci.
Yes, Tom Verducci for the record. You know, I wanted to point out, as far as the cancer concierge, I've seen what Washoe County does. Washoe County has a employee assistance phone number that any member of the county employee or their family members, you know, if they're experiencing stress, mental anxiety, any concerns with bill paying, there's a toll-free number. I'm suggesting maybe we look into what the county is providing as far as employee assistance phone number. I think it's even a 24-hour number. I've sat through a few presentations. It was very impressive as far as what they do have available. You know, I also wanted to point out or ask, I don't believe that we have restored the HSA contributions to pre-pandemic levels. You know, obviously I haven't seen the budget, the two budgets that have been submitted. I believe it was for, you know, single individual 1,100, and you know, I think that was reduced to about 600. So I'm not positive that we've looked into that. You know, I also wanted to point out the long-term disability. I heard it said it only affects NSHE. I do believe that it affects the average state employee and retiree. I think those were eliminated. So I heard it pointed out that it was NSHE, and I think it was the larger entire population. Could be wrong, or
This is Laura Freed. Again, like I said, the state population that is on PERS has access to disability insurance from PERS. NSHE Professional is not on PERS. They have their own retirement. That's why they're not able to access that option.
so it was my interpretation.
Also, Washoe County, you talked about your employee assistance. The state of Nevada has an employee assistance contract. It's run out of the Department of Administration rather than PEB, but we do have EAP, if that's what you're referring to.
Okay, I see. So it's a benefit that's available, but ran through a different agency. And in terms of the elimination of the EPO plan, you know, I don't see that really as being an advantage. I see the justification that there's administrative burdens, but I think the intention would be to have a comparable HMO plan that we have set up in the South that would avoid catastrophe in terms of an employee that is trying to have zero copays, zero deductibles. And in terms of just the complete elimination, I don't think that's the right direction. I think we'd want to be looking at some kind of replacement. And there is an issue here of out of network. And it was pointed out that maybe it could be advertised in a better fashion, that if someone might be out of network, perhaps during the enrollment, they could be choosing a different plan that might be more suitable for them. So those were my comments. And, you know, one of the bigger concerns is the HSA state contributions. I'm not really sure if we really are recommending a restoration of those benefits. So just want to point that out for the record.
So Laura Rich for the record, Tom, that our second budget did include an increase in HSA funding. Now remember, pre-pandemic, the low deductible plan, which does have a zero deductible right now, didn't exist. And so you have to have, when you have three plans, you have to have the three plans differentiate, right? And the way that that's differentiated in insurance speak is called actuarial value. And so you have the EPO or HMO that has a richer benefit, but higher out-of-pocket costs initially, your premiums, right? Your premiums are much higher. Then you've got the low deductible plan, which is kind of that middle plan where it's a compromise. In this case, though, it's actually fairly comparable to the EPO today and HMO. It's not identical, but it's fairly comparable and has lower premiums as well. And then you have the high deductible plan, and so you can't just increase HSA to that high deductible plan without doing something else to the other two as well, because of otherwise you get three plans that are the same, right? And so you want people to have different choices.
Thank you. And if there was an elimination of the EPO, wouldn't we have a quite different plan that's offered up north than what would be available down south? You know, I believe it's our intention to have something comparable, I believe, that they have down south with.
So the reason, sorry.
I'm sorry.
So the reason that we did, that we replaced the HMO with the EPO in the north originally was because having a self-funded EPO was, it was better financially for us, right? We were more efficient at lower costs. We were able to do it. PEB does not have the overhead. We don't pay the 3% tax, you know, that a fully insured provider or insurance provider does, right? So we were able to do it at a lower cost, to administer this program at a lower cost. Regardless, because of the access issues in the north, this is going to exist. It's just whether, you know, PEB staff and our vendors have to administer it, or another provider, insurance provider, let's just say Hometown Health, that was our previous one, that is going to come at a cost, right? Because again, there's no access in the north. We have very significant access issues. Betsy mentioned GI. It's taking months to get into a GI doctor, dermatologist, things like that, right? So what's happening is that we're sending these people out of network, right? Because there's no providers in the north, regardless of who the insurer is, because of that model and the way that it's a regional type model. And the reason it's built that way is because it contains costs in a network. There are no out-of-network benefits, right? So it's a narrow network. So replacing it would just be a more expensive option of the same.
Has there been any consideration of having a statewide HMO plan that mirrors each other, just so we don't disadvantage one group regionally or geographically? Seems like the northern part of the state here is no longer going to have a plan available. It's an elimination of a benefit, and looks like it would force them into the low deductible plan. So anyway, researching a new HMO option and looking at the out-of-network issues and perhaps putting a fix on the other plans that could be part of the problem that's bringing us to the discussion of the elimination of the EPO.
So to be fair, we're not voting on eliminating the EPO today. So that's just something that we are discussing, whether it is something that the board has an appetite for in terms of the analysis on it. If there is absolutely no appetite for it, then there's no point in doing the analysis. I will say that, gosh, this had to be, it was before we put the EPO plan in place. So I think it was like 6 years ago, maybe something like that. There was analysis done, and potentially, having that HMO be statewide. The HMO in the South was determined at that time to be, we couldn't compete with it. Their pricing, their model down there, HPM's model was definitely something that we could not replicate. And so that was, and I can pull up the analysis, it's been years, so, or we can redo that analysis as well. But that was something that we also considered at the time.
Yeah, let me jump in here. This is Laura Freed. Yeah, that's always been the problem. Not always, but for years, that's been the problem. The South, because healthcare costs are just fundamentally lower, ends up subsidizing, if you will, the HMO participants in the North, and that makes resentful participants in the South. So a statewide HMO still has those problems, hence the EPO. Okay, I'll move to Member Kelly.
Thank you, Chair Freed. Okay, so at the risk of just irritating the committee, I'm very on the board. I'm sorry about this. I wanted to talk about LTD again. I know it's a political hot potato. Firstly, I just wanted to clarify. I think someone said that PERS offers disability insurance, and they actually don't offer disability insurance. They do have a disability component to the PERS program, which NSHE classified employees are in PERS. I want to put that out there. So we do work with the disability program through PERS, but the way it works is that a person who becomes disabled and goes through the process would be paid the retirement allowance they've earned without reduction to early retirement. And so when I look at the numbers, so for long-term employees, the PERS accumulator is 2.67% per year of service, right? So if we have, if we say long-term disability paid at 60%, it would take 22.47 years for a classified employee to earn 60% of their retirement earnings and get paid that if they became disabled. So after 22.5 years, they would earn 60% of their retirement benefit and be paid that as long as they're retired. The new accumulator, though, is 2.5%. And so for those people who are hired under that PERS program, it's over 24 years before they've accumulated 60% of their income. And so if a person is in the PERS program or they're an NSHE employee in the RPA program, the long-term disability benefit did pay for those people who became disabled. And the way it would work with a PERS employee is that the insurance company that holds the LTD policy deducts that PERS income from whatever they pay the employee. So they guarantee 60%. If an employee has earned 40% through their PERS service and is approved through their disability program, the LTD piece picked up the extra 20% as long as they were disabled. And so I think that is different from just, like 24 years is a long term to be employed before you get 60% if you're disabled. And I think, obviously people who become disabled have medical bills, they have all kinds of, as well as their regular bills going on that they need to cover. And so I think that, I think saying that NSHE is the only beneficiary, or NSHE employees are the only beneficiary of an LTD policy is a little simplistic, because I do think it covers all employees. It definitely covers executive branch employees until they hit their 22 or 24 years of service in some way. And so I just wanted to put that out there and put LTD back on the table, even though I know it's a hot potato, but I just wanted the record to be correct on that. So thank you.
Well, I'll jump in because I feel like my words have been misconstrued. I just need to restate that I never said it didn't pertain to NSHE classified. I noted it that NSHE professionals are the only ones who don't have access to PERS disability, nor did I ever represent it was great insurance. You're absolutely correct that LTD helps buy it up, but LTD is also expensive based on the money that we have. So I don't think it's that it's a political hot potato, it's that it's pricey. And I'll leave it at that. And I didn't take it off the table. And I'll let Laura Rich jump.
Laura Rich, for the record, the reason you do not see long-term disability on this list is because per our budget, we have $9.5 million in differential cash or excess reserves. LTD is over that. To fund LTD, it would be upwards of 10 million, just by a quick, estimate. So we don't have the ability to fund it using the money we have today. We also offered as a voluntary benefit. There are, I don't have the numbers right in front of me, but there has been an uptick in members who have purchased that product as well.
Member Aiello.
Just a quick question. In the restoration budget, the full budget that went to the governor, the long-term disability as well as the life insurance is in that too, or it's only the health plan to restore benefits back?
Nope, we added long-term disability and the reduction in life insurance as well as HSA. And then it was a very, very small number to restore the benefit portions because we're so close already to restoring the benefit, or we've already gotten to that point through the excess that we've used to restore. So a lot of that budget is really the additional costs are coming from HSA, LTD, really it's LTD for the most part, and life insurance.
So the summary would be that the board did send that forward and it will be both at the governor and the legislative process and for advocacy then, is what I'm hearing.
That is correct.
All right, so what I'm hearing in terms of consensus is a couple of things. Number one, almost everybody would like the PEB staff to research cancer concierge programs. Number two, there is a desire to look into medical travel. And third, there was scattered conversation about premium credits. And although this was sort of couched in terms of health savings and health reimbursement contributions, but to make it equal, I think what I mean, and I think what staff means by premium credits here is the same amount of premium credit to everybody for the employee only. Because if you're doing anything for other coverage tiers, you're necessarily giving certain coverage tiers more than others. So that's what it sounds like to me, that we have three things for staff to work on here: cancer concierge, medical travel, and premium credits.
I think the better question would be, is there anything on this list that is not worth time exploring?
Oh, okay.
Yeah, because my discussion wasn't that I didn't think the things weren't good. I just wanted to make sure in the exploration that we found out that they were working somewhere else, and then what was the key to making them work, not that I didn't think they were good.
Okay. Well, thank you for that. And thank you, Laura, for sort of flipping the question on its head. In terms of things that the board doesn't want to look into, sounds like elimination of EPO plan would be the only one on that list that people don't want to look into. Member Kelly. You're muted.
I'm sorry. Thank you. I would just wanted to bring up doctor on demand for the mental health or the behavioral health things, because given that the executive officer Rich has flagged that there's already a shortage of providers in Nevada, is that worth exploring, given that we're already having issues for our participants getting appointments? That would be the only one.
Ms. McClendon?
I'm in favor of looking into doctors on demand as an option for people who don't have local providers who have availability for behavioral health. But my concern is that I have heard some, given the way, so the online therapy companies have been running into some problematic things. I'm thinking of Better Health and Talkspace and places like that. So given those concerns, I just want to see if, as we're doing research, is there any way that we can look into what participants' experiences are with online providers? I'd really love to see some of that information if it's possible to find it. Thanks.
So for the record, I just want to clarify, we already do offer doctor on demand behavioral health. That's already in place. What we're proposing here is incentivizing that utilization. So driving kind of an incentive to say, hey, we know there's a mental health shortage. We know it's really difficult to get into see, you're a counselor or a mental health provider. Why don't you try doctor on demand, right? And potentially incentivizing that so that people start exploring it as an option. But you are correct that, maybe this is something we need to look at in terms of, are people happy with it, right?
Yeah, I'm sure I'm just going a little too far down this rabbit hole because of my professional background, but I am concerned that people's experiences, I've heard of people who have bad experiences, but again, I'm not suggesting, it's anecdotal, right? So I don't know if that's universal. And I'm just afraid that if somebody really needs care and they reach out for care and they get really bad care, like they're not getting help for their problem and the problem could be exacerbated and worsened, which I guess is like a worst case scenario. So that's where my question is coming from. Not so much that I think that it's a bad benefit to offer, that we should stop offering it, but if we incentivize it and make people sort of lean towards that option, are they going to get quality care? Thanks.
Okay, thank you. Mr. Verducci.
Yes, Tom Verducci. I see 7 items that are listed here, and the last one, the elimination of the EPO, I don't think, there's a lot of support in terms of just eliminating it, but I don't see anything wrong. These are research items, researching the first 6 and dropping the elimination on the 7 in terms of the EPO. And there could even be some wording rather than elimination, determining options for the EPO rather than a complete elimination. But I'm okay with the first 6, just that elimination. I really don't see that really benefiting the membership unless there's a replacement in order.
Okay, thank you.
Was that a motion?
I'm sorry, Ms. Middleton, what was that?
I was just asking Mr. Verducci if that was a motion.
Tom Verducci for the record, yes. I was thinking about bringing that up as a motion.
Okay.
And so be it. There's a motion.
All right. Thank you. Do I have a second on that motion? This would be a motion to ask PEB staff to research Real Appeal, Hinge Health, Cancer Concierge, medical travel, premium credits, and incentivization of doctor on demand for behavioral health.
This is Leslie, I'll second.
Thank you. Okay. I saw that Mr. Barnes has his hand up. Mr. Barnes, would you like to go ahead?
I was just going to agree with Mr. Verducci. I think maybe we could possibly research alternatives to the Northern EPO, like a statewide HMO or a statewide self-funded plan with out-of-state networks, something like that. So I was basically agreeing with Mr. Verducci.
Okay. So
Laura Rich for the record. An HMO is defined as a narrow network. So it's really, that would be a PPO that you're describing, Mr. Barnes. And so we already have a high deductible plan and we already have a low deductible plan. An HMO by definition does not have out of network benefits.
Okay, thank you.
all right, so it's been moved and seconded to have the staff come back at the next meeting with some details on the 6 things shown on page 3 of the staff report, excluding the 7th thing shown on page 4. All in favor, say aye.
Aye.
Aye. Any opposed, say no.
Aye.
Okay, motion carries. Thank you. Let's move to agenda item 11, contracts. This is very limited.
I will be giving this one as well. It's going to be very short. Let me pull it up here. Really, there's not much here on the contract report. We have gotten through the last 2 years of contracts, and the only thing that we have is the status of current solicitations. And I just wanted to bring up a little update on the eligibility and enrollment system RFP. So as the board can recall, PEB ended its contract with LSI. We terminated it early as a result of a lot of the issues that we were having with implementing an eligibility and enrollment system. Shortly after, the state, the Office of Project Management, also chose to terminate their contract with LSI early as well for the statewide ERP system. So as we, is something that we thought was very important as we moved down this RFP process and developing a solicitation was, lessons learned. We learned a whole lot of lessons during this process. And one of the things that we learned was that PEB touches everything payroll related, everything DHRM related. There's a whole lot of overlap. And while we understand, we recognize that only half of our population falls under central payroll, or actually it's a little bit over half of the population. NSHE is the other largest part of that population. And then you've got the small section of boards and commissions and things like that we cover. But for the most part, the largest cross-section here of our membership falls under central payroll. And so this is a very, very important project. If the state is implementing an ERP and upgrading their payroll solution and HR solution and things like that, we are going to need to work very, very closely in terms of aligning our requirements and timelines and things like that, especially if we're using different vendors. So we are working with the Office of Project Management on this. There's several different options in place that we're exploring. I expect to bring this back to the board probably at a later date, likely at the December board meeting. There's also a possibility too, the other thing that we learned is that in a typical eligibility and enrollment system, there is not the accounting component that is required by PEB, right? So that's not offered as a standard solution in a eligibility and enrollment system product. So, and we know that this is not offered through anybody because LSI did actually go out and look for other potential solutions, and there was nobody, none of the eligibility and enrollment system vendors had that in place, and that would need to be something that was customized. So there is a potential also that this RFP turns into 2 RFPs. We are working very closely with our consultants at Siegel to identify the requirements and see if, what path we're going to take moving forward. We have a little bit of time to to develop this RFP, but again, it is very, very important. If the more time we can have to implement, the better. 2 years is the minimum in my mind. So, longer if possible. So this is something that we're really, we've already started on, but there's potentially different options that might be presented to the board moving forward based on the conversations with the Office of Project Management and the work with our consultants as well. And that is it. There is nothing. This report is very bare for the first time in a long time.
Yeah, this is an action item, but I don't believe there's any action for the board to take, so.
That was an oversight on our part.
Yeah, okay, no, it's fine. It's fine to leave it as an action item. I don't think, just because it is, doesn't mean the board has to do anything. So thank you for that. And we'll move on to item 12, which is the second public comment period. So I'll throw it to PEB staff.
All right, one moment, Madam Chair. As a reminder, Zoom is used for public comment only. This meeting is streaming live on YouTube, and if you want to just listen to the PEB board meeting, the YouTube link is located on the agenda. For those who have joined for public comment, your name or last 4 digits of the phone number will be announced, and you will be advised that you've been unmuted. As a reminder for those on the phones, please press *6 to unmute. Please slowly state and spell your name for the record, and then proceed with your comments. Due to time considerations, each caller will be limited to 3 minutes. Kent Irvin, you have permission to speak.
Thank you. Kent Irvin, K-E-N-T-E-R-V-I-N for the Nevada Faculty Alliance. We work to empower our faculty members to be fully engaged in our mission to help students succeed. I just want to thank you all for the discussions today about future benefits and trying to get back to the pre-pandemic level. A couple of points. The health savings account contributions, particularly for dependents, have not been restored to pre-pandemic levels. And that's really something that needs to be looked at. If that affects the placement of the high deductible plan relative to the other plans, then appropriate adjustments can be made to the other plans to keep the appropriate spread of actuarial values. Regarding PERS, not only do all of our classified colleagues at NSHE, not only are they members of PERS, about 15% of the professional employees, faculty, administrative and academic faculty are members of PERS last I checked. And that's because once you're on PERS in the state, you're always on PERS. And so it's not just the classified staff alone at NSHE that are on PERS, but more importantly, as was pointed out, the PERS disability early retirement is not a replacement for long-term disability insurance, which is the essential income safety net for a person who, and we all are one diagnosis away or one injury away from being disabled and unable to work anymore. And if you have that cancer diagnosis, we heard about how hard it is to navigate the system. Well, if you can't afford rent about the time you're going into hospice because you no longer have this long-term disability income safety net, that's really cruel. Thank you.
Thank you, Mr. Irvin. Doug Unger, you have been unmuted. Please slowly spell and state your name for the record if you wish to make public comment. Doug Unger, if you wish to make public comment, please unmute your microphone. Madam Chair, there is no one else for public comment. Do you want to give it a minute just in case more people roll in, or do you want to conclude
Sure,
it?
why don't we hold for another minute or two? Thanks.
Perfect. Doug Unger, you have permission to speak.
Doug Unger, D-O-U-G-U-N-G-E-R, President UNLV Chapter, Nevada Faculty Alliance and Government Affairs Representative. Thank you, Chair Freed and members of the board for your good discussion today. And I would like to back up what my colleague President Irvin said about long-term disability insurance being an absolute necessity, especially for our younger faculty members who don't quite realize they should buy the voluntary coverage. I just want to say that this state worker crisis is hugely acute, and I hope everyone on the board really understands what a crisis it is. I think it's going to take at least 5 years and 2 legislative sessions to fix it. And restoring PEP benefits and making them very, very attractive is going to be one big part of that. By my calculations, and this is just a back of the envelope calculation, in order to really fix entry-level salaries and benefits of the $800 million in the estimated budget surplus that's in our budget now, I actually think our state is going to need to spend half of that in order to address the situation, and probably that much again during the next legislative session. All of this is going to require us working together to try to convince our state leaders that this must be fixed, and also to put the burden on them. On one side of the aisle, understanding and admitting that in their passion to provide for the disenfranchised with progressive policies, they neglected to take care of workers who do the hard labor to implement those policies. And on the other side of the aisle, due to ideological zeal never to consider revenue enhancements, they have committed to starving our state of the resources needed actually to be a functioning state. I hope every member of this board will join us in making sure that our state leaders understand the crisis, how dire it is, and that we're really at the edge of a catastrophe in order to be a functioning state. Thank you for doing your part to help restore the benefits to pre-pandemic levels and even improve them as much as possible to make state employment attractive once more. Thank you.
Madam Chair, that concludes public comment.
Okay, thank you very much. With that, it is 12:39 p.m. I will thank the committee, or excuse me, the board, for its service today, and we are adjourned.
Thank you, Madam Chair.